request all the delegates to occupy the front rows. Learned delegates and academicians, invited dignitaries, on behalf of Nitte deemed to be University and Organizing Committee, I, Dr. Shilpa, your host for the day, extend to you all a very good morning and a warm welcome to the continuing medical education program on impact of cytogenetic analysis in oncotherapy on the occasion of the decennial celebration of Kshema Center for Genetic Services. Without any further ado, we will begin this CME with the first talk for the day on cytogenetic and molecular cytogenetic abnormalities and their clinical relevance in hematologic malignancies by Dr. Jairam S. Kadandale, Director, Center for Human Genetics, Bengaluru. I request our chairperson, Dr. Padma Shetty, Professor, Department of Pathology, KS Hegde Medical Academy, to introduce our invitee speaker. I request all the delegates to kindly maintain silence.
Good morning. I will be introducing Dr. Jairam S. Kadandale. Dr. Jairam S. Kadandale graduated from MGM College, Udupi and completed his MSc and PhD in cytogenetics from University of Mysore. He pursued his postdoctoral fellowship at the Department of Microbiology and Cell Biology, Indian Institute of Science, from 1991 to 1996. He worked as a postdoctoral scientist on the advancement of amniocentesis procedure from 16 weeks to 14 weeks and development of appropriate procedures for fluorescent in situ hybridization on uncultured amniocytes for the detection of known aneuploidies. Dr. Jairam was successful in inventing the PRINCE technique, that is primed in situ labeling technique, to localize single copy genes. He received his license as specialist in clinical and molecular cytogenetics from the state of Tennessee, USA. With his exemplary work and achievements, he joined the Center for Human Genetics, Bangalore, in the year 2001 as assistant professor and later became professor. He is currently the director and head of clinical and molecular cytogenetics division. He has set up a state-of-art facility at the Center for Human Genetics for prenatal, postnatal, and cancer genetic diagnostics using the advanced molecular cytogenetic techniques like fluorescence in situ hybridization, primed in situ labeling technique, spectral karyotyping, multicolor FISH, multicolor banding, and interface chromosome profiling to confirm or rule out various chromosomal abnormalities and complex chromosomal rearrangements. He has 35 years of experience in clinical cytogenetics and well known for giving second opinions, conducting short-term training courses, conferences, and FISH workshops, and training in immortalization of lymphocytes using Epstein-Barr virus. He was instrumental in setting up the Kshema Genetic Diagnostic Services at KS Hegde Medical Hospital and serving as scientific advisor and adjunct professor in the above facility. His main focus of research is breakpoint mapping of apparently balanced chromosomal translocations in families with abnormal phenotypes to identify disease genes in the breakpoint regions. He has several publications in national and international journals and received several research grants from DBT, ICMR, and DHR. He was instrumental in developing the immortalization of lymphocytes by Epstein-Barr virus with support from DBT Government of India. He has helped set up basic genetic diagnostic facilities in more than 16 hospitals and medical colleges and delivered more than 200 talks at various continuing medical education programs across Karnataka and other states. He is a consultant at Clinical Cytogenetics at the Department of Anatomy, Sri Siddhartha Medical College, Tumkur, and SS Institute of Medical Sciences and Research Center, Davangere. He is also an e-consultant for the electronic cytogenetic reporting for the Johns Hopkins affiliated Amcare Labs, Kuala Lumpur, and also for DNA Laboratory, Kuala Lumpur, Malaysia. He has a total of 28 years of experience in cytogenetics, 19 years of experience in clinical cytogenetics and fluorescence in situ hybridization for prenatal, neonatal, microdeletions, and cancer diagnostics. He has conducted several workshops on fluorescence in situ hybridization, including spectral karyotyping, multicolor fish, and embanding. He has been a member of ICMR, National Project Review and Steering Committee on Human Genetics. Recently, in the year 2018, he has been conferred with the prestigious David A. Hungerford Chair at the Center for Human Genetics. Yeah, thank you. I now hand over the chair to Sir Jairam Kadandale.
Thank you, ma'am, for that wonderful introduction. May I now request Dr. Jairam S. Kadandale to invite to the lectern to give away his lecture.
Good morning, all of you. It's a nice morning after a long, rainy days last week. And especially in Bangalore, we had that tough weather along with chilled breeze. And we have just come out of that. And I hope that you're also feeling good today morning. Now, on the occasion of Professor Prashant Shetty's, retirement superannuation program, I feel happy to report out and say something about from last 10 years what has happened in the genetic laboratory. In his term, and which he has started these genetic services long back, 10, 11 years back, and how he has initiated, how he wanted to start this genetic diagnostic center as Shema, and how much effort he has put, and because it was new at that time, which was not accepted by anybody, everybody. Mainly we started doing these things towards the postnatal diagnostics, genetic diagnostics. Slowly then it picked up, and then we could identify several syndromes. We were helpful in doing that, which helped a lot in genetic counseling of these patients and to manage these patients with genetic results, without which it would have been difficult for them to suspect and treat the patients and manage the patients. At the same time, we changed over from conventional cytogenetics to introduce fish-based diagnostics, which was also equally important in prenatal diagnostics, where otherwise we would have taken 15-20 days to report the genetic culture report of amniotic fluid, chorionic villi, all these things. But he was dare enough to start this fluorescent in situ hybridization fish-based diagnostic for the prenatal diagnostics, where without culturing the cells, do the fish on uncultured cells and give out the report within 24 hours after it reached the laboratory, where it was very successful and people appreciated that approach. And for the whole area of Dakshina Kannada, it was new. And otherwise, they were sending these samples outside. It is to the sample from Dakshina Kannada, Mangalore, Udupi, all around, Calicut, all these people, it is to go to Mumbai or Delhi and get diagnosed. And there is nobody to have a interpersonal contact to clarify if you have any doubt. But when it has been introduced here, they were able to contact directly Dr. Prashant and clarify their doubts. So like that, the third step, what he has taken is he's directly started the cancer diagnostics, which was a new of its own. Otherwise, these samples were taken away to Mumbai or Delhi by private agencies. And then you had to wait till they report. And even to clarify the doubts, whatever questions you have asked, it was difficult to approach them because it's a commercial units. There is no direct person in contact to clarify the doubts. That was the main drawback. When it started at Shema, people started calling. The doctors themselves started calling and asked, why this report is like this? Because we were not getting this kind of results earlier when we were sending the samples outside. That was the appreciation we started getting, which was new and which was very helpful for the patient treatment. which really we appreciate the doctor's feedback that we need this, we need this. For that sake, instead of only culturing bone marrows from the patient samples, we started doing fish. We started using the single probes to identify various kinds of cancer to confirm. At the same time, we started developing, depending on the doctor's need, we started developing multiple probes in a panel, for example, multiple myeloma, MDS. So those panels were introduced. That was really appreciated because the many questions were answered in one reaction and one step, and we could clarify their doubts. And the treatment, they didn't wait for the complete report to come out. They immediately targeted therapies were started, and it was very helpful for the patients, not losing time. These are the plus points, whatever has happened in the last 10 to 12 years. And a lot of improvements have happened. And now the stage is at this, where we are standing at present at Kshema Genetic Services is at most equal to any of the best laboratories in the country, because you are offering everything. That's what I wanted to say, that we are not less of anybody. We have full-fledged facility during using these recent technologies and high-end technologies. We collaborate and get it from wherever the places, like spectral karyotyping or multicolor fish, all those things, wherever it is applicable, because you cannot set up for 1 or 2 samples here itself. The facility cannot be set up here. So you can pull the sample and send it somewhere in the research laboratories where it is applied, and you can ask the question and they will clarify that. That's what he is collaborating with Center for Human Genetics, and we are helping for the high-end technologies. Otherwise, all other technology and the instrumentation, everything has been set up here, and it's working so fine. So I just want to compliment him to making this facility survive, and then even in the revenue side also it is doing very well. And helping a lot of in-house patients who are in-house or around Mangalore itself. For example, KMC, Yanepoya, all these doctors are very happy in sending samples and getting their own reports. So with that small note, congratulating Dr. Prashant's work, and then I will start and then show you some of the results what we have done here at the genetic services, what he has reported out to the various different hospitals around Mangalore, and which was helpful. And you can see how helpful when the doctors who come here to speak, they might give this, may not be the complete cytogenetic report, but the way they treated those patients, I think that will very well correlate it to those results. And for that reason, even pathologists who are here, who have recommended the samples, and for example, breast cancer, they have done the immunohistochemistry in their lab, the IHC, and they have the equivocal results where we could help them in identifying, in confirming breast cancer confirmation. Yes, what you are seeing is correct, or what you are seeing is wrong. That we could use DNA probes in showing them where HER2 probes are used to study the amplification of HER2 gene in breast cancer cases. So that was a big help, which was not set up in many of the laboratories. Here, because of the pathologists where they are asking question mark, we could help them out in that way. So many things we are going along with the other investigations, whatever has been done, the pathology department or in the other DNA analysis report, it is going very well. And I'm happy to say that, mainly because everything works so well in the last 10 years, because it's not an easy thing to introduce genetics in any of the hospitals. So this is one of the best hospitals who started this center, and I hope that it will survive for many more years. With that short note, I will start my talk and try to cover all the investigations what we have done here, and then what Dr. Prashant has reported out, how it has helped the doctors, that they themselves will, clinicians will express their feelings. So I will start with I will start and talk only about the cancer cytogenetics. And to start with, it's not only the cancer itself, go straight to cancer. I will start from the chromosome, how it helps to diagnose many patients who are like Breakage syndrome patients. To name a leukemia as AML or CML or APML, that's easy. But before that, when children are going through the anemic patients, when they come, and they complain. To diagnose these people as Fanconi's or ataxia or Bloom syndrome, or you can call it as xeroderma pigmentosa. All these problems are mainly because of the chromosome breakage is what they have. It's in general, it's called a genome instability in those individuals, which leads to this kind of anemic problems, and then where they have the problem of DNA repair. That ends in chromosome breakages, which you can see. What we do is we induce these breakages and see and give you the ratio so that patients can be treated well. If not attended, these patients will end up having cancer, either glioblastoma, or they can get into AML, acute myeloid leukemia. Before that, these patients can be treated so well. This is one best example I can give you. This is how the chromosome breakages looks like after we induce the lymphocytes with mitomycin C. And where you can see these breakages, there are so many breakages which is not seen in normal individuals. One in Fanconi anemia or ataxia or Bloom syndrome, you can see these kind of breakages. This has two different types of breakage. One is chromosome breakage, you can see here an X chromosome here, and another is called chromatid break. These are all DNA breaks, which is found on chromosome in two different ways, chromosome as well as chromatid breaks, which is helpful. You can see here, they are unable to repair this. We as normal individuals, we also go through these breakages, but next day it is corrected. When you smoke, when you have some drinks, when you are exposed to some kind of radiation, everybody gets this kind of breakage, not this kind of breakage, small breakages, micro breaks, that which is repaired on its own in the genome. Next day itself you will be all right. But it never goes to this kind of breakages where you can see these breaks so easily and then count. This is called chromosome breakage syndrome. And another feature of this chromosome breakage syndrome is called radial arrangement of chromosomes. When you culture these lymphocytes, these are cultured differently, where you induce these things using mitomycin C, and then you see this kind of radial arrangements of chromosomes. You can see each and every chromosome has stickiness, breakages at the tip, telomeres are lost, they come and attach themselves and make this kind of radial arrangements. There are different chromosomes, and this is another feature what we look in the Fanconi anemia patients. To confirm 100% this is a breakage, we always grow another control sample from a normal individual and compare these results. So this is very, very useful, which is not done in many laboratories at all. It comes to few laboratories where it is, because it's difficult to analyze, and the number of metaphases what we analyze is too high. And you have to have SOPs, proper SOPs, standardized, and it should work every time because you cannot do the standardization every day. It has to be proven, and then only you can try out these techniques. So getting into the leukemia, that is the beginning, and this is the application, direct application of studies. Regular chromosome analysis or fish studies can be done. As you know, all of you know that leukemias are cancers that start in cells that would normally develop into different types of blood cells. Now, leukemias may be acute or chronic, and they may be myeloid or lymphoblastic or lymphocytic. So these things can happen anywhere, either myeloid or lymphocytic. And then they can be divided into four main types. One is called AML, acute myeloid leukemia. Second is CML, chronic myeloid leukemia. In ALL, that is acute lymphocytic leukemia. CLL, chronic lymphocytic leukemias. The karyotype of leukemic cell is the strongest prognostic factor for response to induction of therapy and survival. If you can get the chromosomes, that's the best. Only problem is it takes time. That's a disadvantage. So for those reasons we use fish studies, and then that we'll deal later. But this is a basic. And if you want to study the whole genome, this is the only way you can study the whole genome without spending too much money. Now, for example, the cytogenetic markers found in AML, like inversion 16, translocation 1616, translocation 821, translocation 1517, all these things are seen as genetic markers in each and every different types of AMLs. Okay. Now, what we see, if you have these things, it's better to have these inversion and translocations of known chromosomes, which can be treated very well, which can easily go for the targeted therapy. If not, if you find these kind of -5, and 5q deletion, 7, minus 7, that is, whole 7 is deleted, 7q deletion, only part of 7 chromosome is deleted, 11q23, inversion 3, translocation 3, depending on the markers whatever we have seen, that the clinicians will take care whether it can go for the target therapy or not. That's the advantage. So these things helps a lot in treatment part. It's not only diagnosis, it's even the treatment is very, very important. So that is the usefulness of studying this genome and by doing karyotyping. The cytogenetic risk groups based on treatment outcomes, they say that depending on what marker you have, either favorable or intermediate or unfavorable. So these 3 categories we follow: favorable, unfavorable or intermediate, depending on the markers what we have. Now these groups accounts for, varies 20%, 50%, 30% of cases of AML, different types of AML, and respectively unfavorable risk category include AML with complex cytogenetics. When you have too many complications in the karyotype, those things cannot be treated, the stage is already passed. So those patients will not respond to the therapy whatever you expect. That's the reason why we say that it gets complicated. Those complicated cases I will give you some examples to see. Now, as you said, dealt with just like I was explaining about CML, AML, APML, everybody, our most common markers what we see on regular basis is the CML with translocation 922, where the 922, the product of 922, translocation between 9 and 22 is called Philadelphia chromosome. That is the one which people are looking for the targeted therapy. Clinicians are just looking for this one, whether this patient can go for targeted therapy or not. So that's a helpful message what we give. And we also use BCR-ABL. BCR is on chromosome 22, ABL is on chromosome 9. These are the 2 genes what we look for. And without doing karyotyping, we can directly do the FISH and see the signals whether it has been translocated or not on uncultured bone marrow cells. So that is the advantage by doing FISH, which I will give you the example. In AML patients, usually in general we look for translocation 821. First we rule out this one. And in APML or APL, promyelocytic leukemia, we look for the translocation of 1517, which is the FISH probe what we use is PML RARA, and for 821 we use AML ETO. And FISH panels what we developed, which are most commonly used, are multiple myeloma, which has these many translocations, deletions, and translocation mainly and deletions found on these cells. Bone marrow cells, mainly we use bone marrow cells to analyze. MDS, multiple myelodysplastic syndrome, has the marker of deletion 5q, deletion 7 or minus 5, minus 7, which will be helpful for the treatment. And in ALL, you can look at the panel using translocation 922 probe, translocation 1221, 11q deletion. All these things are the markers which are found in different kind of leukemias. Now, this is the best example. I am dealing with only the CML to start with. CML has been identified long back time in 1960s just by looking the chromosomes under microscope. They never had any other means of saying that it is CML. They said it is CML in where they have a chromosome 22 which was looking totally different from normal. This is the Philadelphia chromosome, a product because of the translocation between chromosome 9 at this region to chromosome 22. This much is deleted, this has come here, this has gone here. The second chromosome 22, abnormal chromosome 22, we call it as Philadelphia chromosome because it has been identified in that place, Philadelphia in US. And then David Hungerford is the person who identified at that time. And so this has been the genetic marker since then, even now for the targeted therapy. At that time it was only a translocation between 9 and 22. Then slowly in 1970s they found that this is the region Q341.12, Q11.2 on chromosome 22. This is the translocation region. And then they found out ABL is the gene which we can target at this breakpoint region. And then BCR on chromosome 22 we can target as a gene of exchange between these two. So later on what happened? So this is how a single fusion probe has been developed to identify this translocation. You need not go for the chromosome analysis. You can use a FISH probe where you can take out and label the ABL gene in red and label the BCR gene which is on chromosome 22 in green, and background blue is DAPI. And when you analyze cells bone marrow cells, you will see 2 red spots, 2 green spots, which are normal, which is called normal. And when you see a yellow signal and 1 red and 1 green refers to normal chromosome 22 and 9, where the yellow signal is the merger of breakpoints of BCR and ABL. So that is the marker what we see here. So without analyzing chromosomes, easily you can say that this is positive, this is negative. So looking at the nuclei, count the nuclei and then give the percentage, whether it is positive, 70% positive, 90%, 100%, 20%. After the treatment also, need not go for the bone marrow. You can get the blood sample from the individual who have gone through the treatment, say it is still existing or not by analyzing the similar way. Then it can come down to, after the treatment regime, to 5% or to 0%. So that is the way it has been monitored also. Therapy which has worked or not, we can monitor the patients easily. So this is how you can see using a single fusion probe, 2 red, 2 green, normal, all these are normal, all these are abnormal, 1 yellow, and each and every nucleus. These are all nuclei from bone marrow cells. Now this is how we identify, and then which is helpful for treatment of these patients. Now you can see that we slowly developed a double fusion probe, where we label both 9 as well as 22, both the ways, which will avoid some confusions. So for that reason, double fusion probes have been developed, where the 9 as well as 22 appears in yellow. You can see here, this is the Philadelphia chromosome, this is the reverse, that 9, which lights up in fusion. So that counting will be easy on the chromosomes, we won't miss it. If there is a variation in translocation between 9 and 22, if it has 3-way translocation, any other translocation, easily you can find out if one is there, the other is not there. Then it's 100% that there is a variance what we can see in the cultured cells. But by fish, you can see only one signal, even after using dual fusion. So that's where the question mark comes. All those complicated things, we use different approaches to prove it. Now this, because of that double fusion probe, you end up like having 2 normal to 2 green to red. It can be like 2 fusion, 1 red, 1 green, or it can be 1 fusion, 1 red, 2 green. It can be 1 fusion, 2 red and 1 green. It can be 1 fluorescent, fusion signal and 1 green, 1 red, or it can be 3 fusion and 1 red and 1 green, or it can be 1 fusion, 2 red and 2 green. So these are the variants. These are the genes what we are looking at on chromosome 22 and 9. So variant chromosomes, variant signals will be seen. That is the most complicated thing what we see. So it is not straightforward when you analyze only the nuclei. You are not looking at the chromosomes. Now these are the DNA sequences what we have hybridized, and then it gives different kinds of fusion signals. You have to interpret based on these things and say this is what is happening, because you are deciding and saying yes, this can go for the treatment or not. And if it is variant, you have to prove what is the variant, because that will not respond to the therapy. So because of that you have to prove it. So chromosomes is the only way you can do it. So this is how we do fish analysis for the chronic myeloid leukemia patients to confirm 922 translocations. Now you can see that it's not only Philadelphia chromosome can exist in 1 copy. That's the product of translocation between 9 and 22. But you can see here 22, abnormal 22, which is called Philadelphia chromosome. We write it as PH plus in the report. And the other cell line, and it has 2 Philadelphia chromosomes, PH plus, PH plus. So this is the severity of chromosomes, severity of the disease also. And then you can see this nomenclature where it shows there are 2 PH chromosomes in one cell line. This is the clonal evolution in these patients, clonal evolution in the leukemia CML patients. And here CML with double PH chromosome and additional abnormality with ISO 17q. There is one more abnormality in these cell lines. You can see this, and hence this recommended for clinical correlation. Whatever the results, pathology results, what they get, it has to be correlated well with that before the treatment. That's how we give out all this complete report where clinician can take a proper decision. Especially with the children, they can get these things. So now this is another example of additional PH chromosome, and then translocation is between 9, 22 and 21. 9, 22 and 21. It is not a straightforward translocation. It's between 9, 22 and then 21. You can see using fish, you get only one signal and one green, one red, another red and green here for 21. So there's total confusion when you look at the signals. But we know that because of the experience, and then not doing this also, we can say that there is a variation, which we always recommend that chromosome has to be studied. Otherwise you will not, giving a proper result. Then finally it says, this is the product of 922, Philadelphia chromosome is there. This patient can go through the clinical, treatment regime, not because of it has three-way translocation, just because Philadelphia chromosome is there, positive. That's important rather than different variant translocations. So that's an advantage by doing both the technique. This is not for all the patients, only for the questionable patients, patient samples we do this. You can see here, now this is the blood and cultured peripheral blood, which says that it's an atypical fish signal pattern. Each signal pattern seen is typically associated with a particular chromosome abnormality, hence recommended for clinical correlation. Compare the results with conventional cytogenetic results because it has different pattern of signals than what we expected. So these things we just cannot propose or conclude, and then these cells has to be cultured and looked at the complete karyotype, and then only decision can be made. So because of the different pattern, we will see how it looks like. You can see there is a translocation between 1, 9 and 22. 22 comes and sits here. So this kind of variations, you can see this is the spectral karyotyping of this individual, where it says three-way translocation. You can see only one pH is existing here still, even after having 1, 9, 22 translocation, because ABL and BCR combination is still there, Philadelphia. But to confirm, you have to have this result, either by karyotyping or other things. And this is how the abnormal chromosome 9 and abnormal chromosome 22 looks like, 1, 9, 22. So it's easy to do this kind of things using different technology and prove it before this thing goes for treatment. Now you can see here there is a straightforward translocation between 9 and 22, and this is the normal cell line. You can see normal cell line number is more, percentage of normal cells are more. Still there is only one cell here. We don't know whether this patient has gone through the treatment. This is an example that unless you give the proper clinical details, the diagnosis will be misdiagnosed. We will leave out this one if there is only one, which should not be left out. Because if it is after the treatment and it is if it is a blood, we are very careful. And if this is either it is relapse or whether it is a treatment which is worked and the treatment still should increase or continue, this we don't know. Because the percentage of pH positive cells is very, very less. So this is more, normal cells are more. So the cytogenetic analysis revealed normal karyotype in most of the cells along with one cell having translocation 922, which we don't neglect. Hence, it is advised for molecular cytogenetic fish-based studies where we can get more percentage study with BCR-able probe to confirm the clonal abnormality. Whether that clonal abnormality what we have seen is really one cell or it is more, because where we can count more number of nuclei in fish studies. Here it is only chromosomes. Now, moving from chronic myeloid leukemia, the complications and the variations whatever we see, we will go to acute myeloid leukemia and see the markers and then see how we do it. Now, as I told you, the genetic marker what is seen in the leukemia, acute is referred as acute leukemia, where you have to use this probe and then confirm or do the karyotype and then confirm the genetic marker. Easily we could see that there is a translocation between 8 and 21 AML ETO probe, which will help us by doing the fish also to confirm. So this is the genetic marker what they are looking for the treatment purpose. So what is this XX 821 translocation? Acute myeloid leukemia with translocation 821 AML M2 subtype. So this is a confirmation what we are giving it. Once it is confirmed, this patient also can go through the targeted therapy. That's the advantage of identifying these genetic markers. And this kind of quality chromosomes getting from bone marrow is not easy. Not always it works. Especially ALN, MLL, CLL, very difficult to get chromosomes itself. And moving forward, this is a 35-year-old female with APML, suspected APML, acute promyelocytic leukemia. You can see that there is a straightforward translocation between 9 and 10, and then there is a plus 21, and it's a 35-year-old. So what we see is this 21, when we see in 3 copies, always goes with trisomy 21 is frequently seen in patients with acute myeloid leukemia, AMLs. Not only 821. This is another genetic marker what we see, and this also can go through the treatment. And these are the different genetic markers what we see in AMLs. And like I explained earlier, and you can see this is a 35-year-old female. Now move forward, we can see there is a 2-year female child, 2-year-old female child with bone marrow what we have analyzed, and you can see different clonal evolution in this patient. Clone 1 has hyperdiploidy. Hyper means 3 copies of 11, 3 copies of 8, and 3 copies of 21. There are many chromosomes are in 3 sets, like trisomies for these kind of chromosomes, which is we call it as hyperdiploidy, more than diploid number. And clone 2, you can see that there is a additional methylene chromosome 6 and trisomy for 11 and trisomy for 21. Now just to rule out, when we write 21C, it is constitutional. We want to rule out trisomy for chromosome 8, what we have seen here, and chromosome 11 are seen in Downs in AML cases. But the problem is that trisomy 21, because of this trisomy 21, we recommend that this patient blood sample can be cultured and reconfirmed for trisomy 21, whether it is constitutional or not. If it is constitutional, this has to be neglected. Otherwise, this has to be considered for the treatment. So it's trisomy 8 is considered as genetic marker, but 21 is questionable because of its 2-year-old. If it is not Down syndrome patient, then it's easy. It's good. So only for children in this kind of cases we recommend for blood karyotyping. So that's another genetic marker we saw in children below age of 2 years or newborns, or children born after 6 months, 1 year with leukemia. Now you can see here APML, is a AML case M3 type. The cultured peripheral blood is showing hyperdiploid cells. Can you see trisomy for 7, 8, 9, 11, as well as tetrasomy for chromosome 13, trisomy for 14. So with all these things, what you recommend is another abnormality is ISO 17. So we generally write that these are the symptoms of hyperdiploid cells found frequently with gain of chromosome 7, 8, 9, 10, all these things. Along with non-specific clonal abnormality, this is the abnormal, and there are much more abnormalities also. For that reason, we write non-specific clonal abnormality which are not considered as genetic markers in these cases, and recommended for clinical correlation. So this is how we give out the report, which they can correlate with their reports, other pathology reports, and then take a decision on that. Now, this is a 41-year-old male with a bone marrow sample what we analyzed. This is a clear-cut trisomy 11 and a case where trisomy 11 is an isolated rare abnormality. It's not the straightforward abnormality. It's a rare chromosomal abnormality found in acute myeloid leukemia and is associated with poor prognosis. It doesn't respond to your therapy. So that's the, in advance you know that why the patient is not responding. So this is because of only one clone, clonal evolution with trisomy for 11, chromosome 11. Like that, these things can be easily identified using fish probes, AML, using different genetic marker, using different genes for those breakpoints on chromosome 8 and 11. It's called, AML and AML1 and ETO probes. And in case of PML, we can use translocation 15-17 using PML RARA probes on 15 and 17. So interpretation is, these are all normal hybridization pattern, to red to green. And you can see fish evaluation using AML1 ETO probe confirmed monosomy for 56% of cells. And for chromosome 21, you can see here, monosomy for chromosome 21. These are split signals for the same chromosome. And along with normal cells, monosomy 21 mosaicism, hence suggested for clinical correlation. This is a 71-year-old male. So this monosomy is not good. They won't respond to the therapy. So monosome is always dangerous. This is for the chromosome 21 in 56% of the cells, which is not good. And AML1 confirming, this is confirming trisomy for chromosome 8. Just by doing FISH itself you can see there are trisomy, there are 3 signals for chromosome 8 in 44% of cells. And these are the genetic marker which we can identify without even culturing cells also. We can do this and give out the reports, which will be helpful to look at the markers. And this is a 44-year-old AML patient again with bone marrow cells in a female, and you can see the 11q deletion. 11q23 is another genetic marker for the treatment. So here it's confirmed just by doing the bone marrow culture, and it proves that deletion 11, all cells are having 11q deletion, 23 deletion, which is has a good prognosis. And now deletion 11q23 is known to be associated with AML M5. We can stage it, hence recommended to clinically correlate the results. So it is very advantageous to look at these different markers, how it is helpful for the treatment. Now in this case you have straightforward translocation between 15-17. You can see that 15-17. Only thing is there is a deletion of chromosome 3 also, which is not good. And this is good for good prognosis for the treatment. 15-7 translocation between 15-17, which is consistent with APML or APL. That's the genetic marker what we are proving that it is good for the good prognosis. By doing the FISH for PML RARA by using dual FISH, also you can make that double fusion probes showing that fusion signal which directly confirms there is a fusion translocation between translocation 15 and 17, and positive for translocation 15, 17 and fusion for PML RARA genes, which is a good prognosis for these patients to be treated. And APML, another case with PML RARA and variation most probably, positive for the fusion of PML RARA, which is seen on chromosome also. But it is having only one fusion signal. But when we do the chromosomes, luckily we had some chromosomes on the bone marrow culture itself, uncultured cells itself, but that showed there is one signal on chromosome 15-17, which is appearing on chromosome 15, which is good for the treatment purpose. So it's not a variation. Now in APML, that's acute promyelocytic leukemia, you can see that there are these cells is positive for translocation between 15-17, but not straightforward. But the other clonal evolution which has 15-17, but 17 is different, where you can expect that the second signal, what we couldn't see only one signal for fusion signal, is because of this. Here it was showing positive but 2 signals, but here it was showing only one signal because this 17 looks different from normal 17. That's why we could see only one signal for chromosome 15, which can go through the treatment. This is the advantage by culturing the cells to prove those cases, why we are looking at getting only one fusion signal, even though we have used dual fusion probe. So positive for translocation 15-17 along with variant translocation, this is the variant translocation, hence recommended to clinically correlate. And in the karyotype we mentioned 46XY translocation 15-17 question mark 17. So question mark 17 is here. So that's the reason why we have given the 2 different clones picture also clearly. In case of myelodysplastic syndrome, MDS, which is also equally important, where we look for genetic markers like 5q minus, and then this has 3 different abnormalities, which is considered, even though it has 12p abnormality and 13q deletion. So this is the one which helps in diagnosing this and confirming this 5q deletion is very, very important for their treatment. And here deletion 5q is the most frequent cytogenetic aberration in MDS, hence suggested for clinical correlation, and they can take a chance in treating these patients just by having one marker 5q. Same way the other one in MDS also 7q deletion, our whole chromosome 7 is deleted, is also equally important. Monosomy 7 or deletion 7q is known to be associated with MDS or acute myeloid leukemia, hence recommended for clinical correlation. Either 5q or minus 5 or 7q minus or deletion 7q or deletion of whole 7 is very, very important to be considered as genetic marker for these APML patients. You can see monosomy 7 here in the same MDS patients. We confirm this disease by having monosomy 7. Now here trisomy 8, this is a clonal evolution and it model number is 46. Trisomy 8 is most common gain in MDS. So this goes towards MDS now, AMLs towards MDS, and hence suggested for clinical correlation, which is a genetic marker in these MDS cases. Now this one, it has trisomy 8, but also it has minus monosomy 11 with marker chromosome. You can see here marker trisomy 8, which we consider is very good, important for the treatment purpose, and leave it out. The other abnormalities we don't consider at all. And in this case you can see inversion 7, since it has found in all the cells, in bone marrow cells, you can see that this is not considered now for the treatment purpose. The above abnormality is suspected to be a constitutional, not the clonal evolution in this case, because it's found in each and every cell. Because of that, it is considered as constitutional. Now normal, using deletion panel for deletion for 5q as a genetic marker for MDS as well as 7q is used to study is the normal 7 and these are the normal 5s. So when it is abnormal deletion 7q, you will have only one signal rather than having two signals. You can see here clearly. So this is how by FISH probes we can easily identify the abnormalities, these genetic markers, which can avoid and which can save time in giving out the reports. Now in this case you can see in the MDS case you can see minus 17 and in you can see minus 9, trisomy for chromosome 19 and or abnormalities on chromosome 14. So here gain of long arm of chromosome 14q is seen in MDS. These are not important. This is very, very important for the treatment purpose. 46XX iso 14 for iso chromosome for Q arm of 14, which is very important and considered as genetic marker in MDS also. And now last, it won't take much time, I'll just deal with another one or two examples and then leave it out. So multiple myeloma is another leukemic problem. Leukemia problem. You can see in multiple myeloma we always look for this kind of hypodiploidy and hypodiploidy. Hyperdiploidy, you can see the trisomy 3, trisomy 5, 7, 9, tetrasomy for 11, trisomy for 17, 19, 22. All these things are seen, and marker chromosome which you don't know what it is. So these are the common things what we look at in for MD multiple myeloma cases. You can put the karyotype like this. And we write these results clearly in results part, not only ISA nomenclature, which says 54 to 56 as the model number. The chromosome number in these cases varies from 54 to 56, having minus, plus, translocation, all these things are mentioned. Hyperdiploidy is one most common thing which appears here. So same thing can be identified by using these kind of probes to analyze the translocations found on translocation 1114, translocation 414, translocation 1420, and then 13, deletion 13 RBN gene, retinoblastoma gene, deletion 17p, this is for p53. All these genes can be studied, and then those hyperdiploid cells can be analyzed here also. So all these panels are very, very easy to mix up, and depending on the doctor's requirement, what he is looking at, depending on the genetic marker what he is asking us, we develop this kind of panels and analyze and then give the results quickly. Now you can see multiple myeloma not only having the one what I have told you, the hyperdiploidy. This is a spectral karyotyping of a rare abnormality in multiple myeloma which is having so many translocations and various translocations. By looking at the color itself you can say what has gone from where to where. See all these abnormalities which you would have not given this result by just by doing karyotype, because it's not easy to say this part has come from where, this part from where, because these are all hyperdiploid cells losing some of the things, deletion, translocation, inversion, say it. So you can see there are around 19 or 20 different events happening in this karyotype. So they won't respond to anything, any treatment. So this is the specialty of multiple myeloma, having this kind of multiple translocations, which is very, very dangerous to get. So, and at the same time they develop into different clonal evolution and have some other difficulties in translocation. And problems in its in the cells. So in ALL, acute lymphoblastic leukemia, you have these kind of probes, panels what we can develop instead of looking at karyotype directly. Translocation 922, translocation *11q23 are the MLL rearrangement on these 11q deletion cases. Translocation 1222, 1221 and hyperdiploid cells and hyperdiploidy, that also can be studied. Translocation between 514, translocation between 514 because IGH on here is very, very important on chromosome 14 and ETV RUNX1, MLL rearrangement, BCR-ABL, all these things holds good in analyzing these ALL patients, and they are all considered as genetic markers. You can see -2, -18, and this is called hyperdiploidy, where you have less than diploid number. It varies. Different chromosomes gets lost in different Then now you can see hyperdiploidy is known to be associated with acute lymphoblastic leukemia, suggested to correlate the results. Now at the same time, you can see here hyperdiploidy is equally important, and other than hyperdiploidy, you can see this kind of translocations abnormal which are not considered as genetic markers. Hyperdiploidy or hyperdiploidy is very, very important for these patients to be treated. Hyperdiploidy is also known to be associated with ALL cases, which is very, very important. And you can see this ALL 5 years male bone marrow sample. The cultured bone marrow cells showed composite karyotype containing clonal abnormalities, where composite karyotype is little different, mainly because these are not in each and every cell gives you different karyotypes. So for that what we do is we count different cells, different karyotypes, and combine all those results and say it's a composite karyotype. By counting 7 metaphases, we got these many results. The variation in the chromosome number started as model number as 46, but it varied from 46 to 52, having the 6 chromosome as XY, even though here it is XXY in this karyotype, and a male patient, and these many abnormalities have been seen. +6, +6, +8, +8, 10, all these things in general we consider this as hyperdiploidy, which is very important, and to know the abnormalities what is going on those patients. This is a 2-year-old bone marrow sample from a male patient, which is clearly showing abnormality on chromosome 6, that is a deletion on chromosome 6, which is very important. Deletion 6 is the most common recurrent cytogenetic abnormality in B cell small lymphocytic lymphoma, hence suggestive for clinical correlation. So these are very helpful in confirming the genetic markers in different kinds of ALLs. And then this is another example. 9p is also, deletion of 9p is also equally important for the treatment purpose, and the deletion of 9p is common recurring chromosomal aberration in ALL of both B cell as well as T cell lineages, and seen in approximately 7 to 11% of children with ALL. You can see this deletion on chromosome 9. So these patients with this kind of deletion, equally important to know. It's not only using different gene analysis or fish DNA probes to analyze and then say. Even karyotyping is very, very helpful in these cases. So this is a 7-year-old male patient, bone marrow sample, which has this cultured bone marrow cell showed a clonal non-specific structural abnormality. You can't expect all the time when you use fish probes or chromosomal analysis, expect genetic markers which are important for the treatment purpose. Sometimes you get this kind of clonal evolution which are not important for the treatment purpose. There are different clonal evolution happening with different translocations, like the structural abnormalities, which we leave out. Means we don't report these cases at all. It may be having, but it is not good for treatment purpose or considered to be reported as genetic problem. Now like that, you can use this kind of different fish panel like BCR-ABL. This is B cell lymphoblastic lymphoma case, where we have used this panel using BCR-ABL and translocation 922, tell AML gene for translocation 1221 and MLL break apart probe. This is the 11q23. This is normal because this is called a split apart probe, which is in normal it shows as yellow. When there is a translocation, this gets separated. One looks green, another looks red. That's called split apart probes. And very important in using these fish probes as a panel to analyze these ALL patients. results interpretation, the above ALL fish panel probes, BCR, ABL, TLML and MLL showed normal hybridization pattern and negative for any kind of rearrangement. This is the normal report what we give using these fish probes. Like that, you can see that the same thing when it is positive for ALL, you can see this BCR ABL is normal. Here the results shows that trisomy for chromosome 22 in 90% of cells. Trisomy for chromosome 22 in 90% of the cells. You can see that trisomy for chromosome 22. 3 signals for green. Just by looking at these spots, you can decide and say that. Now, and 76% of cells tetrasomy here and 15% of the cells trisomy for chromosome 11. You can see this 3 copies instead of having 2 copies. So these are the analysis part, what is important, and hyperdiploidy, all these things can be confirmed even by using the fish probes. You can see clearly this is a 63-year-old patient which is referred for the ALL case. Referral of ALL case, bone marrow sample. You can see this BCR ABL has confirmed positive for 922 translocation in around 22% of cells. There, only one genetic marker is positive, all others are negative. So this is also equally important for the treatment purpose. So at the end, the last one I can say, highlight on this chronic lymphocytic leukemia CLL patients in 2 slides using these fish probes, how we can develop and how we are applying this fish probe panel to analyze CLL patients. These CLL patients, it is difficult to get chromosomes. Many of the time we say that culture failure. They don't grow properly in culture. Because of that, fish probes are very useful. You can use the translocation 11, 14 and then translocation 12, 21 using these particular genes of that junction point, break point, and then use RB1 gene on chromosome 13 where it shows whether it is deleted or not, and then P53 on chromosome 17p. This is the normal. We can study all these in a panel and say what is missing, what is not missing, whether it is a translocation found or not, whether the genetic marker what you are looking at is there or not. So gene amplification is the last one what we can see in the solid tumors. You can see FGFR, MYC, NMYC, CMYC and then HER2. These are the genetic markers found as amplified DNA or genes in solid tumors. It is not easy to grow these solid tumors. Either you give us the FNA sample, fine needle aspirate to analyze, or give the tissue biopsy and then it goes through paraffin embedded sections. One side you do the IHC, the other side we confirm the equivocal cases by fish probes using this HER2 probe. I can show what we are doing in the schema, and this is the HER2 gene which is on chromosome 17. The green color is to identify chromosome 17. The red color what you see is the gene, that specific gene, HER2 gene sitting on chromosome 17, Q11.2 region. You have 2 copies of 17 and 2 copies of this particular gene. This is what is suspected in a normal individual. Now you can see these are the individual cells what they has been hybridized with the HER2 probe. 2 green for 17, 2 red for the gene of interest. That's a HER2. Now you can see this is the section. You can see paraffin embedded section which has been sent because they found the equivocal results from the IHC immunohistochemistry. So what we have done is we hybridized HER2 probe and seen 2 signals each for green and red, that is HER2 and the control green. You can see here 2 signals in each and every cell. This is a patch of section what is being highlighted for hybridization with the fish probe. Same thing what you would have seen under the IHC after you do the IHC. So when you see those 2 signals, it says that it is normal. Now when you see this kind of amplification of HER2 gene, you see this kind of patchy thing. Green is the HER2 gene. You can see the amount of HER2 amplification here. This amplification is not happening only on chromosome. Amplification, what I mean is duplication of that particular gene on a particular chromosome. When it happens on that particular chromosome 17, it shows homogeneously staining region. It is called HSR. Okay, or it can be translocated to many other chromosomes. So this is how it looks under the paraffin embedded section. You can't see anything, any chromosomes or anything here. But the same thing, if you do it on chromosome or on a metaphase, you will see where all it has gone. So the product here is the one what is important. So it is abnormal. This is called positive for the HER2 amplification. So equally, when you have question, it is, we have been asked to clarify the doubt. This is how we clarify whether it is normal or abnormal. Amplification, amount of amplification is not important. Yes or no is important. So I think, thank you very much for your patience. And
Thank you, sir, for that informative talk. Any questions from the audience?
Sir, very good presentation.
thank you.
Most of your karyotype, particularly AML, is having trisomy.
Yeah.
It's a Down syndrome. Why this Down syndrome, cases are having this AML?
It's not Down syndrome. Down syndrome, earlier they used to live, for 20, 25 years, and then management was so poor and other things. Nowadays, from last 20 years, their lifetime has increased because the good management of those children with Down syndrome, and counseling has been helpful in those cases, genetic counseling, and because of that, their lifetime has increased from 25, 30 to now it has been up to 55, 60 years also. So these Down syndrome patients in later stages of life, they not only have the cardiac problem, okay, they will develop AML in later stages. But it's a coincidence, here in children who are under the age of 2 years, when they have trisomy 21, it's a genetic marker. But we don't consider as a genetic marker for the treatment immediately.
Thank you, sir, for the enlightening talk on karyotyping. We would like to continue the programs.
Thank you, sir. As a token of our love and appreciation for your time and valuable contribution, may I now request our chairperson, Dr. Padma Shetty, to kindly present a memento to the invitee speaker.
Because of the dignitaries are here, and I just wanted to mention again that what we discussed in the beginning before the talk, what we are doing, cancer cytogenetics. Today I gave a talk only on cancer cytogenetics, and how it is useful for the doctors to treat the patients, whether it is AML, CML, APML, or whether it is multiple myeloma, myelodysplastic syndrome, CLL, ALL, all those patients, how they have been treated, how best the results have been given from here to either to Anapoya or a KMC or any other regions here around Mangalore. And the genetic services at Kshema, as I am just going to repeat, it has not only was successful in treating these abnormal children, genetically abnormal children like common Down syndrome patient, Turner syndrome, all these people. We went ahead, and then the second stage we introduced the prenatal diagnostics to avoid this, to tell them in advance what is going to happen in next pregnancy. Those genetic counseling has been done, recommended for the prenatal diagnosis, which worked so well, and it's going on very well. Third stage we have improved and then gotten into cancer diagnostics, which has picked up very nicely and more than what we expected, and then appreciation has come from all the doctors who are sending the samples. And I was mentioning that the facility what we have at Kshema for genetic services is the best, one of the best services, not only for these kind of leukemias, even for breast cancer diagnosis. We are doing it on regular basis, which is helping for the doctors to treat this HER2 positive Herceptin treatment for that matter, where they can 100% say that yes, it is HER2 positive, which can go for Herceptin targeted therapy. So I'm thankful, doctor, for developing this genetic laboratory so well at genetic services at the Kshema, and for the dignitaries to helping us and then supporting us so much. And I'm also thankful and then say that congratulated Dr. Prashant Shetty to keep going and then do a good job. What he has done from last 10 years, really appreciative work what he has done. And thank you so much. And then
I request our chairperson, Dr. Padma Shetty, to kindly present a memento to the invitee speaker. Thank you, ma'am. May I now request Dr. Prashant Shetty to present a certificate to our chairperson, Dr. Padma Shetty. Thank you, ma'am. Thank you, sir. Now it's time for the formal inauguration program, but before that, we have a small intro to the milestones of Kshema Center for Genetic Services. May I now call upon Dr. Sucheta Kumari N to the lectern to give us an insight to the milestones achieved by Kshema Center for Genetic Services over the past decade.
Good morning to all of you. It's a very nice morning for us from Central Research Lab Kshema. I am Dr. Sucheta, in front of you presenting our 10 years of work on cytogenetics. Here I have to start with some of our story to think of the genetic lab. Actually, 2012, we conducted a very good biomedicine conference interrelating with all our 8 institutes. So that happened to meet Dr. Prashant Shetty. Even though he was my senior, we never used to meet him. But Prashant Shetty told I was interested to start a cytogenetic lab in Pharmacy College. Then I caught him. Then Jairam Shetty and Prashant Shetty classmates, and I knew them in Mysore University. And then that time our budding research center was started at A.B. Shetty, and we are about to shift to the Kshema building. And then we started to discuss what is necessary, how to start, what are they. Actually, innocently we started. Now we know how difficult to sustain the lab. So all of you, this is not a thing when starting it is, we are very interested. So first time we need around 1 crore of rupees for the lab. So how to, we met that time our VC, present VC was a dean, and he said you meet the chancellor. So we went chancellor to meet about the requirements, space and everything. And sir asked so many questions with Dr. Jairam Shetty. Hardly more than 6 times, 10 times we met him. 2 hours he used to listen about every other gene. Then finally asked, when there is no therapy, why do you want to diagnose? So then we once again counsel, we have told, by analyzing, there may be we reduce the complication, treatment modality will be increased. Like that we convinced, then he agreed to give the fund and start the lab. So 1 year, it's very difficult to get a technical support and to take care of the lab development. So what we did is almost on 2013 to 14, we have standardized the lab. There are P&DP permission, so many things. And then they said we should have the trained certificate to start the lab. So myself, Prashant Shetty, then Katyayani madam, we went to Center of Human Genetics. We trained ourselves how to do the lab working. Then we came and gave our certificate so that the proper lab setting started. Then we had, for our good luck, Dr. Meenakshi joined here, and she also helped to develop in the preliminary stage. And now she has taken up the job at Lalpath. But in between we had our Reshma madam. It's a very difficult task to sustain the lab. So here I wanted to with these stories, how it is Kshema Center for Genetic Service is a diagnostic facility started in July 2013. When pioneers come together, we can expect the unexpected. Sri N. Vinay Chancellor, Nitte deemed to be University, who is the backbone for this initiative and provided all the support which was required for this outset. At that time, our VC, Dr. Satish Kumar Bandari, was dean. He was so supported for each and every startup of the center, timely support and guidance during this inception. Such an incredible achievement was achieved when a dedicated team, that means I'm not praising myself, Prashant Shetty and Dr. Jairam Shetty. So he made to exist this lab. This dedicated team has helped to think about the importance of diagnostic laboratory. Although the lab started in 2013, standardization of the diagnostic procedure were concluded in January 2014. It is indeed a proud moment for us, as this is the only one diagnostic laboratory in whole Dakshina Kannada and Udupi district. Here also I have to mention one thing. In my tenure of lifespan, 38 years of service here, the clinical lab, every alternative to one lab will exist. But for last 10 years, one single lab in Dakshina Kannada and Udupi district, we have not found a diagnostic lab in the hospital section. But the labs are there in Lalpath, SRL, Thyrocare, that is the private labs. They charge more and they are by the scientist, by paying high salary and incentives. So it's very difficult to sustain the lab in any in hospital section. This is the clinical cytogenetic laboratory at Kesagda Medical Academy is a modern state-of-art cytogenetics testing facilities, engages for both diagnostic research and teaching. The laboratory offers a broad profile of service by conventional karyotyping and a FISH is a gold standard method. So there is no alternative method, and it helps to prenatal, postnatal cases. The cancer screening along with conventional karyotyping, different FISH panels have been made for multiple myeloma, acute myeloid leukemia, acute lymphoid leukemia, myeloplastic syndrome, chronic myeloid leukemia and breast cancer. So for all these cases, we have our own doctors who are utilize the lab services. They will be witnessing and explaining the use. The graph of our lab depicts the progress over the years since its inception. More than 2,450 samples received so far, as we are constantly engaged with the several oncologists, gynecologists and pediatricians and in and around Mangalore. So if you see the services, it looks number is small, but 2,500 samples without any mistakes. The reports and given from the hospital, from our diagnosis center, is the great credibility to our team, and we really have to appreciate any small mistake we will be land in the court. So everything is very, very tedious and incredible service our team has done. No lab is complete without the equipments. We have all the state-of-art equipments, fluorescent microscope, Genesis software, stereo microscope, inverted microscope, fluorescent situ hybridization chamber, carbon dioxide incubator, laminar airflow, fume wood, and all that, all these 10 years without any contamination. The culture, everything they are maintained, our team. We are very grateful to all our team. Reported abnormal cases are either published, we presented so many awards they got, national and international conferences. It is a real feather in our cap to mention that many PhDs are awarded, and also many interns, students and our own staff our own graduates, postgraduates are trained from this lab. We have not only excelled in the field of diagnostic, our staff has also delivered talk on existing genetic diagnostic facility at various esteemed colleges like Father Muller's, AJ. Furthermore, we have signed MOUs with the Father Muller College, Mangalore Center for Human Genetics, Bangalore, Fetal Medicine Center, Mangalore, MDCRC, Coimbatore, In Vitro Lab, and Madurai and High Tech Fertility Center, Coimbatore. Appreciation is a way to success. There is nothing more rewarding than the appreciation we have received. To list a few, PNDT, prenatal diagnostic test approved for genetic lab and are valid up to 2014. Even 2 days back, people inspected our lab. They are very happy. They are promised to support from all over Mangalore. And our lab is now recognized as NABH accredited lab from March 2021. How true is the saying, strength builds up one's confidence. Our strength is the quality report, which is appreciated by all oncologists with the affordable price and best turnover time. Our team is doing the best. They use the sample and do within a given time. Facilities utilized by the PG students, pediatrician, gynecology, oncology, and pathology, and other labs. So this is our 10 years of achievement. I request everybody to give a standing ovation to the team. Thank you so much.
Thank you, ma'am, for that wonderful glimpse of accomplishments of Kshema Center for Genetic Services over the years. Marching forward with the quantum of time, may I now request Dr. Sucheta Kumarian to escort the dignitaries onto the dais. Of applause to all our dignitaries, to all our esteemed dignitaries today. Ladies and gentlemen, as we are now joined by our dignitaries on the dais, let us now begin this inaugural ceremony by seeking the blessing of the Lord Almighty with a prayer song by Ms. Ranjita. I request all of you to kindly rise for the invocation.
Vichaya Vinayakane Gajamukane Karuna Sagarane Vijaya Vinayakane Harihara Brahmaru Anavarata Bhajisuva Harihara Brahmaru Anavarata Bhajisuva Mujagadodaya Ganeshane Vijaya Vinayakane ನೀನೆ ಮೊದಲು ನಿನ್ನಿಂದ ತಾನೇ ಆರಂಭ ಜಗದೊಳೆಲ್ಲ ಮೊದಲ ಪೂಜೆ ನಿನಗಾದ ಮೇಲೆ ಇನ್ನುಳಿದ ಪೂಜೆಯಲ್ಲ ನೀನು ಹರಸಿದರೆ ಯಾವ ಕಾರ್ಯಕ್ಕೂ ವಿಘ್ನವೆಂಬುದಿಲ್ಲ ನೀನು ಹರಸಿದರೆ ಯಾವ ಕಾರ್ಯಕ್ಕೂ ವಿಘ್ನವೆಂಬುದಿಲ್ಲ ವಿಜಯ ವಿನಾಯಕನೇ ಗಜಮುಖನೇ Karuna Sagarane.
Thank you, Ms. Ranjita. To formally welcome the gathering, may I now once again call upon Dr. Sucheta Kumarian, Principal Scientific Officer, Central Research Laboratory, to the lectern.
Good morning, all. I am pleased to extend a warm and hearty welcome to all of you for the CME on impact of cytogenetic analysis on oncotherapy organized by the Kshema Center for Genetic Service in collaboration with the Department of Oncology. KSEGD Medical Academy stands in all its glory today because of the visionary Justice KSEGD, the founder of Nitte institution, Sri N. Vinay Hegde, the Chancellor, followed in his father's footsteps and made this a global education institute. We are happy to have our Honorable Vice Chancellor, Dr. Satish Kumar Bhandari, and he is the guiding force behind this university growth. I extend a delightful welcome, sir. It gives me great pleasure to welcome our Vice Dean, Dr. Jayaprakash Shetty. He is always with us to support for each and every steps in our progress. Thank you, sir. I am glad here to welcome our Dr. Jayaram Shetty Kadandale, Director of Center of Human Genetics, Bangalore, who has taken time from his busy schedule to make us understand the working and the techniques of the genetic lab. I thank you, sir. Welcome you, sir. I want to acknowledge the presence of our guest, that is, we are very grateful to our two invited speakers today's program, Dr. Rajesh Krishnan, consultant hematologist, Yanapaya Medical College and Hospital. Hearty welcome you, sir. And Dr. Harsha Prasad, pediatric hematologist, oncologist, KMC Hospital, Mangalore. Hearty welcome you, sir. And we have an online speaker, Dr. Meenakshi Bhatt, consultant in Clinical Genetics, Center for Human Genetics, Bangalore. We welcome you, madam. And Dr. H.B. Gurushankar, the Professor, Department of Zoology, Central University, Kerala. Welcome you, sir. Then our own people, that is Dr. Jayaram Shetty, the HOD of Oncology Department, our Dr. Vijit Shetty, our Professor in Department of Oncology, and Dr. Prashant Shetty, the Coordinator of Kshemang. And I also welcome Dr. Praveen Shetty was here, R&D Director. He just went for some duty. So I welcome each and everyone here. More than that, our press and media, from the day one in all 10 years, we conducted many workshops and trainings on cytogenetics. So we welcome you, sir. Welcome all press and media and all the dignitaries, HODs, professors and staff. Dr. Veena is here. Our director is here. All of you, we are welcoming for this program. And once again, I extend my all the welcome who are gathered here. Thank you.
Thank you, ma'am, for that warm welcome. May I now call upon Dr. Reshma Shetty, Assistant Professor, Kshema Center for Genetic Services, to present the traditional floral welcome to the dignitaries on the dais. Thank you, ma'am. To start us off on this auspicious note with the divine blessings, we have the lamp lighting ceremony, and may I now request our esteemed chief guest for the day, our Honorable Vice Chancellor, Dr. Satish Kumar Bhandari, and all the dignitaries on the dais to join us in the customary traditional lighting of the lamp and symbolically inaugurating this program. have curated a small ceremony to recognize and honor the contributors for their efforts, as each one of them deserve credit for their continuous support to Kshema Center for Genetic Service in gloriously completing 10 years in diagnostic service. May I now request our Honorable Vice Chancellor Dr. Satish Kumar Bandari to present a certificate of appreciation and memento to Dr. Rajesh Krishna, Consultant Hematologist, Enapoya Medical College, Derlakatte, Mangaluru. Dr. Rajesh Krishna studied MBBS from Government Medical College, Calicut, and MD in General Medicine from Madras Medical College. He then went on to United Kingdom and completed his MRCP. He was trained under world-renowned experts in Imperial College, NH Trust, and University College Hospital, London. He is practicing in medical chambers where his father, late Dr. V.N., but urologist practiced. KSAGDE Medical Academy, Nitte DU takes pride in recognizing his outstanding contributions in the field of oncology and also his continuous support towards Kshema Center for Genetic Services, Central Research Laboratory, KSAGDE Medical Academy. A huge round of applause to Dr. Rajesh Krishna. Thank you, sir. May I request our Honorable Vice Chancellor Dr. Satish Kumar Bandari to present a certificate and memento to Dr. Harsha Prasad, Consultant Pediatrist, Hemato-Oncologist, KMC Hospital, Mangaluru. KSAGDE Medical Academy, Nitte DU takes pride in recognizing his outstanding contributions in the field of oncology and also his continuous support towards Kshema Center for Genetic Services. A huge round of applause to Dr. Harsha Prasad. Moving on, we have our in-house contributors. May I now request our Vice Dean Dr. Jayaprakash Shetty to present the Certificate of Appreciation and a memento to Dr. Jayaram Shetty, Professor and HOD, Department of Oncology, KSAGDE Medical Academy. KSAGDE Medical Academy, Nitte DU takes pride in recognizing his outstanding contributions in the field of oncology and also his continuous support towards Kshema Center for Genetic Services. A huge round of applause to Dr. Jayaram Shetty. May I now request our KSAGDE Medical Academy, Nitte DU takes pride in recognizing his outstanding contributions in the field of oncology and also his continuous support towards Kshema Center for Genetic Services. We have last but not the least, now I request our Honorable Vice Chancellor Dr. Satish Kumar Bandari to present the Certificate of Appreciation and Memento to Dr. Prashant Shetty, Professor, Coordinator, Kshema Center for Genetic Services, the backbone and the driving force behind Kshema Center for Genetic Services. KSAGDE Medical Academy, Nitte DU takes pride in recognizing his outstanding contributions in the field of clinical genetics and also his continuous support to Kshema Center for Genetic Services in gloriously completing its 10 years in service. May I now request Dr. Rajesh Krishna, Consultant Hematologist, Enepoya Medical College, Derlagatte, Mangaluru, to address the gathering.
Respected Vice Chancellor Dr. Satish Bhandari and other dignitaries and colleagues on the dais and all friends and colleagues here. It is a very touching and moving experience to be honored here in front of this august audience. And I must congratulate the department for achieving a glorious 10 years delivering such a noble service to the people of Dakshina Kannada and Kasaragod, and to a lot of patients who come from all over Karnataka. And at the outset, I must say that it is very important that we support local services and develop, because particularly there is no point in, sending off samples across to Bangalore, Bombay or Delhi or outside India. We should try to develop everything within our district. So I'm particularly grateful that they are offering the services, and especially the department is endeavoring to build on its achievements and has got a vision. So all that is wonderful, and I hope that you grow from strength to strength and probably do next generation sequencing and other further steps, so that we can get everything done in Mangalore itself. So that should be our vision for the future. So thank you once again for inviting me. Thanks a lot.
Thank you, sir, for those words of appreciation. May I now request Dr. Harsha Prasad to address the gathering.
Good morning, everybody. Respected Vice Chancellor, Nitte University, Professor Satish Bhandari, sir. Associate Dean, Vice Dean of KSEGDE Medical Academy, Dr. Jayaprakash Shetty, sir. Professor Dr. Prashant Shetty, sir. Other dignitaries on dais, and dear delegates. When I started, I was ex-employee of KSEGDE Medical College, and I got a great regards to the institution. I worked for 8 months in the Department of Pediatrics in 2003. When I started my oncology practice, hematology and oncology practice in Mangalore, I was wondering where to send the sample for cytogenetics. That's the commonest childhood cancer is acute lymphoblastic leukemia. And till date, no test is basically can overcome this cytogenetics. I mean to say, there are so much advanced RNA sequencing, DNA sequencing in childhood leukemia, but cytogenetics part still plays very important role. In 2014, when I started, I used to send to a lab in Delhi called OnQuest. And the transport time itself used to be around 36 hours at least, but by and large 48 hours time. And once you start steroids, the viability of the cells goes down, as well as then you never be able to get the cytogenetics part after starting the therapy. So it is very crucial at the initial part of at the time of diagnosis. And then there was one lab in Manipal, a life science, School of Life Sciences, but somehow didn't get that well. And the reports, the failure rate was quite high when we send obviously to the Delhi, and more than around 30 to 40% of the samples, they couldn't get the culture grown and get the report back. And then one day, Dr. Vijay Shetty made us to meet Dr. Prashant Shetty sir in a meeting. And he said, we have started the services of genetic services in Kshema. Since that day, I haven't turned back. Not a single sample goes outside Mangalore for cytogenetics part at least. And now I started doing the fish as well. I am very happy with the kind of service they provide to us. First of all, local, as Dr. Rajesh Krishna said. Second, very economical when it compared to the multi-speciality or corporate labs, chains of corporate labs. Third, we can talk to them, discuss with them we can request if there was some problem, we can request to do free of cost, which they are obliging. And our patients, some of the majority of them, as you could see, Ayushman Bharat scheme, and quite a few times I requested them that, can we do it again, please? And then more than willing to get it done, the cytogenetic test, and I'm very thankful to the team, and I'm happy to see the way in which the department has grown over the 10 years, and as the madam showed, the graph of the number of samples have gone up, and I'm happy even when Dr. Meenakshi was there, the Nitte Urban Center, we used to rush and give the sample there, because once you do some of the emergency cases, we did the bone marrow aspiration in the afternoon. We try to do everything in the morning so that the sample reaches at 4 o'clock. And she came and picked it up. Sir once said, give it there, then the transport here. So these are the arrangements they did, and I'm very happy with the kind of services providing. And now I started sending the fish sample as well to them for various other conditions. And we continue our support always there. And all the best for future endeavors. With that note, I would thank you.
Thank you, sir, for those words of appreciation. May I now request Dr. Prashant Shetty, Coordinator, Kshema Center for Genetic Service, to address the gathering.
Good morning, respected Vice Chancellor Satish Pandari sir, and the dignitaries on the dais and off the dais. This is a very auspicious moment for me, as we all gathered to celebrate the success of the 10th anniversary of our genetic diagnostic laboratory. I'm indeed obliged for this recognition. I cannot believe that we have completed 10 years service to the society. It has been a milestone in the progress of a young university of 14 years. In 2012, when Dr. Suchata madam and I met Dr. Jairam and discussed starting of a genetic diagnosis laboratory, we met our chancellor, sir, who readily agreed to start the facility under the KSEC Medical Academy. So this laboratory came into its existence in July 2013. In the beginning, we had issues with the technical personnel, which Dr. Jairam fulfilled by appointing experts trained under his guidance in genetics. Many people believe that these genetic diseases are incurable and asked what the use of their diagnosis is, but later they only realized the importance of it, especially its importance in pediatrics, gynecology, and oncology. We have diagnosed around 2,450 patient samples as of date. In the last few years, our oncology samples increased due to the facilities awareness and doctors' faith in our reports. Each of our report is cross-checked by our e-consultant, Dr. Jairam, and then released. On this occasion, I would like to mention an incident. One doctor sent a bone marrow sample for karyotyping with a query of APML. After a week, the same doctor sent a report of the same patient, diagnosed at another lab, which reported the deletion of chromosome 6. But our report showed the typical APML translocation, that is 15-17. And after seeing our report, the doctor appreciated our report, and then he started sending samples to us. This is the importance of an excellent diagnostic laboratory. The lab is not only active in diagnosis, but also in research. 6 students have registered for the PhD, of which 4 students have completed their PhD. The entire journey of these 10 years was a learning experience for me. I take this opportunity to acknowledge the services of Dr. Meenakshi, Dr. Reshma Shetty, Mrs. Vani Shetty, and our beloved research students. I especially thank Mrs. Vani Shetty for her silent nature and technical skills, which led to the analysis without a single mistake in processing the patient samples from culturing to staining. Therefore, may I request Vice Chancellor Sir to present a token of appreciation to Mrs. Vani Shetty.
Thank you, sir. May I now request our beloved Vice Chancellor, Dr. Satish Kumar Bandari, our chief guest for the day, to address the gathering.
Good morning to each one of you gathered here. My good friend and very renowned specialist in the field of genetics, Mr. Dr. Jairam Shetty, the doctorate, Dr. Jairam Shetty, and Mr. Dr. Rakesh Krishna. Again, we are practicing together, and he is son of our former urologist. I think during the inception of the medical school, his father was the urologist, who was very, very gentleman and very nice person to know of. Then Professor Harsha is doing good work in Mangalore, and all other my colleagues, my vice dean, Jayaprakash Shetty, Prashant, and Vijit, and Jairam Shetty, who are sitting in the dais, and my very, very affectionate sister, Sucheta Kumari, who is doing, and all faculty of Nitte University. Reshma is doing good work after Meenakshi's exit. And Vani, who was a technician, was felicitated today. And the scientists who are working in Central Research Laboratory, and my colleagues from university, I see Veena and Kishan Prasad, and the other faculty also of Kshema. And I feel today it's a red letter day in the history of Nitte deemed to be university. Why it's a red letter day? Because the contribution of small things. I think when we started 99, the KSID Medical Academy, you may be knowing, we started with the 2 floors. The people who have come in 99 may not be able to recognize. Jayaprakash Shetty knows how this institution was developed. But we did small things. Whatever some good things come from outside, without much investment. People like Jairam Shetty, any idea comes from outside. That's what Sucheta said. How we started genetics, yes, we'll do it. Nothing, no saying no for anything. Everything, whatever comes, stem cell. I think you are one of the first institution, pioneers in stem cell in the country, in the private sector. Genetics, radiation biology, we did the radiation biology conference also. Biomedicine, we did a conference. Then later, we started Nuxar. Lot of things we did for the research. Even in spite of very, very advanced laboratories, 2014, if you go to our status of our publications, 2014 publications highest in this university, 2014. What it shows that what is required is the people. Instruments, yes, we can get very, very costly, crores of worth to can invest, labs we can have. But what is required? People. People who are dedicated, who feel that is their own. That is very, very, very important. That's the reason this occasion is very, very important for me. People, unless you have got a dedicated people, we can't do anything. That's what I realized in the last, almost now we are reaching, to 99 I joined this institution. We want dedicated people. Unless we get people who are committed, who can't do anything. That's the reason Prashant Shetty or Sucheta or others, or Jayaprakash, others, Prasabadma, or I am not going to name Veena or Kishan or whoever it is there in this gathering. What I acknowledge your human contribution. That's very, very important. And that is the reason this is a historical day for university, 10th year of cytogenetics lab. Because when we started cytogenetics lab, we never thought that it has got so much application. We thought, what cytogenetics? Chromosomes, some abnormalities, deletions. We didn't know that it has got so much application. Now, after getting samples, Others are recognizing the center. It's really a feather in the cap. And rightly said by Rakesh Krishna that local versus global. That's what Modi, Professor, our Prime Minister says. Local versus global. You should empower the local talents. And for, as he said, sending samples to other places we don't know. There may be a lot of mistakes because there is no human-to-human contact. When you're sending the sample, there may be some mistakes. And getting access to the people who are doing the test is also very difficult sometimes. But that's what but particularly in this area, if a small mistake can cause catastrophic implications. It causes a lot of psychological problems or depression to the person who has been affected, who has been told that you are having this disease. And he says it's a death knell, and he says that it's just like a catastrophe has happened in his family, for him or in the family. So you have to be very, very careful. So now the laboratory has been started. You know that the importance of genetics is increasing, because cancer is going to be one of the very important non-communicable diseases. In the second place, I think it's going to take going to be the number one disease. You just take it from me, next 20-25 years, cancer is going to be the number one disease. It's going to beat the cardiovascular disease. But we had the very negative impression about cancer, that it is incurable. Because I know a lot of, in my family, or there are people in the community which I know, when they got breast cancer, and we should say put them on some chemotherapies and some surgery is done. Ultimately, in 1 year, 2 years, when you hear that ovary, it may be ovarian disease, it may be lung cancer, and these are the very, very common cancers, but it was found to be incurable because of the lack of specific diagnosis. Cytopathological, molecular diagnosis was not there. But things have dramatically changed, because my son-in-law is a medical oncologist. I talk to him very frequently. Now the treatment completely it has been changed. What is required? We have to educate the people. I think of breast cancer, now the particular specific molecule targeted therapies have come. It may be lung cancer. You know, we got our own example who lived for 5 years, one of our very important person from our Nitte family. And initially it was told only 6 months. But he lived for a quality life. He led for almost 4 to 5 years. So things have dramatically changed. Cancer is going to be the main important killer, or it's not going to be a killer disease, according to me. It will be the important disease. It has to be diagnosed. Diagnosis level has completely changed. You are going to the molecular level now. Nothing, no clinical, along with the clinical diagnosis, it required to be diagnosed in the cytogenetic or molecular level. So treatment, newer and newer drugs are going to come. Recently I had been to Washington, and the new drugs which are coming in US, we don't have access to such many molecules now. It's daily they are coming out with very, very dramatic drugs. I think yesterday we saw one of the, I don't know how many people have seen that in our WhatsApp university, that how a Parkinson person who is affected with Parkinson, who is immobile, with the one injection he could walk, he could do. None of the hospital. I think I sent it to some neurologist. So my daughter-in-law who is there in Washington, she is a neurophysiologist and neurologist. She says that some drugs worth is crores. One injection costs 8 crores, 10 crores. It is not available in India, but they are giving, government is giving because of insurance they can give. Dramatic neuromuscular diseases, it has been trying. Immunotherapy in cancer is going to come in a big way now. Genetic counseling is, I think, is going to be the order of the day. You can predict which person is going to, which lady is going to develop cancer. Maybe males also can develop breast cancer. Who is going to develop lung cancer? So it has got implications to the diagnosis. So early diagnosis is going to happen. Treatment, specific targeted therapy is also going to happen. So, and prevention of cancer is going to be the future. So, cancer is going to take the leading disease which is going to affect the community, and you have to be geared to develop our laboratories for handling this type of volume, and that the volume also going to be very large. Quality also of the diagnosis also is going to change, and naturally the oncologist, it may be radiation oncologist, medical oncologist or surgical oncologist, they will have lot of work to do, and they will be ably supported by this type of facilities. I think we should, this 10 years, yes, we have done. What is next 10 years? That is very important. So Prashant or Sucheta, and that's what I was talking busily, very involved discussion we had with Jairam Shetty. What to do for the next? It may be not, we can't wait. We have to do something now. How to take it to the next level, that's very, very important. We cannot be complacent, we cannot be relaxed about what you have done in the last 10 years. Yes, you have done. Very good work you have done. But it's going to change. Just recently I had been to Narayana Hridayalaya. The Jairam Shetty may be knowing. 65,000 square feet of space dedicated for genetic engineering. Now they are going to that level. You can change the gene of the person. Suppose he has got a diagnosis as a cancer, you can change the gene. That is going to happen now. You know, already robotic surgeries and other things have done. Human, even robotic doctors are going to come. Pathology, even Jayaprakash Shetty, he will not be without a job, but the things are going to happen. Pathology, because artificial intelligence is going to come now. Padma, be careful. Artificial intelligence, you can send a sample tissue, it will give the diagnosis. 100 times more accurate than what we humans do. So even surgeries. So it is going to, totally is going to change after 3 or 4 or 5 years, or in the next decade, things are going to change. So what is next? So we cannot be very happy that we have done everything and we have achieved. Yes, we have achieved. What is next? So I request all my dear colleagues, may have a strategic plan for your department. Next year or next 2-3 years, what is your goal? After 5 years, what to achieve? After 10 years, what you want to become? Because this is a time, because we have got a very benevolent management. Our Chancellor, N.V. Hegde ji, he's got such a, this morning he called me again. He's talking about nuclear medicine department and what has happened. I'm telling for the last so many months, what happened? The space is ready. Your people are not ordering for the equipment. So can we get a person of that stature who is interested in the development of the university? And nothing goes from here, not a single pie goes outside. Everything is invested on the university. Everything invested on the human and the equipments. So you will not get such management, so you will not get such chancellor. So we have to strengthen his hands. All of you should work towards developing this particular facility, which already, you know, we have tasted that success. So don't allow it. So you say you are among the first cytogenetics lab in this region. But you cannot be second after this. You have to remain first. I think all of you will work for that. I wish whatever help from the university you require, we are willing to provide, maybe space or it may be equipment, but you want human manpower. Manpower is also very important. Yes, we have done it, because I used to do all sorts of cancer surgeries when I was in Venlock Hospital. But nowadays I don't do, because we have got better qualified people. I used to do laryngectomies, I used to do maxillectomy, I used to do reconstruction. I used to pectoris major myocutaneous flap, reconstruction. We have done near total laryngectomy, where even after surgery patient could speak of cancer, removing half of the larynx, retaining half of the larynx. There are many patients of mine still, they are living. They can speak by closing the tracheostomy. So it's called what you call near total laryngectomy. They are very grateful to us. But we did that during 1980s, 90s. But slowly now there are people, now there are MCH, head and neck is there. We have got people who are head and neck oncology, head and neck, there are specific specialists are coming because they have got more qualification. They have got better equipped to handle such cases. So now slowly we are phasing out. But we always relish whatever what we have done during those days. We have done a lot of things which are cancer-related work. People lived, people were happy. But the things have changed. Now the things have gone to the molecular level. Unless I read, I can't speak. I cannot diagnose a particular case. Now they see oral cancer. Now we got HPV has become one of the criteria to treat. Human papilloma virus. It's radiation sensitive. So cancer has become very specific now. So your knowledge, unless you read daily, you become outdated. Particularly in genetics and cancer, unless you read, you have to read. Yes, we'll handhold the people, we'll get good people also to the university. We have got more qualified people also should come. They are not competitors for us. Because now nobody can replace me. I am I. Nobody can replace me because I got my own talents. Nobody should feel that is a threat or he'll come and he'll occupy my space. My importance will go. Nothing. You should be good mentors also sometimes. So with these few words, I once again congratulate Sucheta, Prashant, and the whole team who have done a wonderful work. Because I always appreciate, because I did few projects with Sucheta. BRNS project I did, because I am from the ENT, field of ENT. Now I got a patent on phytoceuticals. We are going to develop a product out of that. So recently I had been to Washington, I talked to Mansoor, and we have talked about our Oroxylum indicum as an anti-cancer drug. He said, we will do something. They are trying, they are interested in that particular drug. So we did a lot of things. So I congratulate once again, wish you all the best, many more years of success. Good luck. Thank you very much for your patient hearing.
Thank you, sir, for that thought-provoking and appreciative address. We are now at the end of this inaugural function. May I now request Dr. Reshma Shetty to deliver the words of gratitude.
Good morning, everyone. It is my immense pleasure to deliver the vote of thanks on the decennial occasion of Kshema Center for Genetic Services. No duty is more urgent than that of returning thanks. On behalf of organizing team, it is my privilege to thank all those who have supported us wholeheartedly. First and foremost, my sincere thanks to Shri N. Vinay Hegde, Chancellor Nitte DU, who is the pillar for this initiation. My heartfelt gratitude to our esteemed guest, Dr. Satish Kumar Bandari, Vice Chancellor, Nitte DU, for accepting our invitation and honored this function with his inspirational thoughts. I would like to thank our beloved Dr. P.S. Prakash, Dean, K. Hegde Medical Academy, Vice Dean Jai Prakash Shetty, for their continuous support. This function would be incomplete if I do not appreciate the willingness shown by Dr. Jairam Shetty and Dr. Vijit Shetty, Department of Oncology, K. Hegde Hospital. We are grateful to our speakers, Dr. Jairam S. Kadandale, Center for Human Genetics, Bengaluru, Dr. Rajesh Krishna, Enapaya Hospital, Mangaluru, Dr. Meenakshi Bhatt, Center for Human Genetics, Bengaluru, and Dr. H.P. Gurushankara, Central University of Kerala, for not only sparing their valuable time to grace this occasion, but also who will be enlightening us with their talk. I also extend my thanks to Dr. Harsha Prasad, KMC Mangaluru, for his outstanding contribution towards Kshema Center for Genetic Services. No event can take place without the hardworking leaders. It is the dedication and enthusiasm of our leaders, Dr. Sucheta Kumari N., Principal Scientific Officer, Central Research Laboratory, and Dr. Prashant Shetty, Coordinator, Kshema Center for Genetic Services, who made this event possible. Conducting this program would have been impossible without the sponsors: Bioimaging Requisites, Hindustan Biotech, Durga Laboratory, Alchemy, Axis Bank Mangaluru. Thank you for your support. Above and beyond, let us not forget the backbone of the CME, the whole organizing team who went an extra mile to make this event a resounding success. I would like to thank all the delegates for their interest in enrolling for the CME and every individuals for being here in making this day. Thank you one and all.
Thank you, ma'am. Before closing the inaugural function, I request you all to kindly rise for the national anthem. For the second talk of the day on insights on cytogenetic reports and hematological cancer treatment by Dr. Rajesh Krishna. Without any further ado, we'll start off with our second talk for the day by Dr. Rajesh Krishna, consultant hematologist, Enapaya Medical College, Derlakatte, Mangaluru, on importance of cytogenetics in hematologic malignancies. Request our chairperson for the session, Dr. Vijit Vittal Shetty, Associate Professor, Department of Oncology, K.S. Hegde Medical Academy, to introduce our speaker.
So, I would like to invite Dr. Rajesh here. He's a good friend. He did his MBBS from Calicut Medical College and then did his MD from MMC Chennai. Then went on to do his FRCP and then MRCP from UK. And he has a lot of publications in national and international journals. So without further ado, I request Dr. Rajesh to please come and deliver his lecture.
It's a humbling experience to speak on importance of cytogenetics in front of a very distinguished audience, particularly Dr. Jairam sir and of course Vijit and Dr. Jairam sir again and Harsha Prasada, and there are, I think, many people know more about this topic than me. So one of the things that I asked when I was asked to speak on this one is, what exactly do you want me to talk about? I was told, talk to us about something that we don't know. So even though I'll be talking about importance of cytogenetics in hematological malignancy, I will try to intersperse it with stories and look at it from a hematologist's perspective. So the first few slides are introductory slides, which I think you may already know. So with regard to cytogenetics, the people who described cell division in the beginning were all botanists. 1842, Carl Nageli spoke about cell division, and then Walter Fleming again described the chromosomal movement during mitosis. Both of them were German botanists. And in 1888, Waldeyer spoke about chromosome. Now, subsequently in the 1940s, Barr body was described, and we began to know more about the X chromosome and its importance. In 1952, the utility of hypotonic saline was discovered, and the correct number of chromosomes were described only subsequently, and was confirmed in 1956 by Ford and Hamilton. The count of chromosomes during the initial days was very rough, so they couldn't really get a accurate counting till the 1970s, when high resolution gene banding made it easier to get an accurate chromosomal count. Then of course, a lot of things in science move forward very fast. In the 80s, they had automated imaging, subsequently color imaging, and also use of probes. And of course, in the current century, single nucleotide polymorphisms and next generation sequencing, and all these have revolutionized the field. Of course, probably this has already been described and will be described. We are talking to you more about the utility of conventional karyotyping in hematology, apart from fish. Obviously, the metaphase is the part of the cell division where you got those centromeres in the equator of the cell, and subsequently you are blocking the mitosis, and subsequently, obviously you are the better experts in doing this. We will run through. Obviously, you need that high resolution microscope. And for people who do not know about fish, now this is the procedure, or this is the method by which fluorescent probes are used to find out whether a particular area of interest is there or not. I will come to talk about it a bit later, and this is quite useful in cancers, particularly hematological malignancy. Again, now we got M-band and fish. You got these color probes, and that's quite helpful. Now, with this brief introduction, let me come to my proper topic per se. Now, conventional karyotyping and fluorescent in situ hybridization helps me as a hematologist in 3 key areas. One is obviously in the diagnosis of the patient. Obviously, without a diagnosis, you cannot treat. The next is, when you make a diagnosis of a cancer, the first thing the patient asks is, what is the stage, doctor? And obviously, what it means is everybody is interested in the prognosis. Will I get cured? How long will I live? So that is the next thing. And subsequently, how to treat the cancer. So treatment decisions. So these are the 3 areas in which you help me. You, in the sense that the Nitte Department of Molecular Genetics helps me in these 3 things for the patient with hematological cancer. How useful is it is the question. Now, obviously, 95% of the chronic myeloid leukemia patients, probably it may be as high as 98 or 99, have got a chromosomal aberration. We will discuss more about it later. More than 60% of the AML, 60% of myelodysplasias, half of the chronic lymphocytic leukemias, majority of the other hematological cancers such as non-Hodgkin lymphomas, myelomas, and acute lymphoblastic leukemias have chromosomal changes. So now we have to understand that. So this is very important. So majority of our cancer patients do have molecular changes, and a lot of them we can detect using conventional karyotype and also fish. So the magnitude of problem that we are facing is huge. When I say magnitude of the problem, This means that how useful this tool is shown by this percentage. That is why every patient who we suspect a diagnosis, we have to do conventional karyotyping. So why I have put this slide first is, see, so as a hematologist, I am quite interested in morphology, and often this is a story of a 30-year-old man who has presented with a white cell count of 400. As you know, the normal white cell count is somewhere between 4 and 10, and white cell count of 400 is very high. He has got headache, and he is quite unwell. He's got a large spleen. So as a hematologist, first thing I think, okay, let's look at the peripheral smear, and we see this sort of a picture whereby for a hematologist, these are features of chronic myeloid leukemia. Now, how do we make a diagnosis? Obviously, this we have to send for conventional karyotyping, and also we sent for FISH for Philadelphia chromosome. And this was the first specific chromosomal aberration linked to a malignancy, to a hematological cancer. So what is Philadelphia chromosome? So this is basically your 922 translocation. And over the last 3 years, from my side, we have sent some 30-40 samples across, and we have seen additional chromosomal changes. So it's not just the Philadelphia chromosome here which helps us to make a diagnosis. Sometimes we get additional chromosomal changes, and we have presented this in a national conference also, along with, of course, with the Nitte, with Shivani presenting it. So what all these have got implications. So what it means is that we have made a diagnosis, and we also see additional changes. So each of that helps us to see, okay, is the disease moving, is there a progression? And obviously I talked about the stage. We got what is called a chronic phase, then accelerated and blast crisis. So it sort of helps us to prognosticate the patient and decide on the treatment options for the patient. So I think this is more for the delegates. So Philadelphia chromosome, what we mean is there is the ABL region of the chromosome 9 and BCR region of the chromosome 22. So these chromosomes break, and there is a translocation. So this is, and we got a BCR ABL coming together. So what does that do? Now, before we talk about what that does is, so this was described in 1960 by Peter Nowell and David Hungerford. So they described that there was an abnormal gene change. So the exact translocation was described in 1972 by Janet Rowley. And that this is the cause of CML was described in 1990. So that is quite recent. And subsequently, what this change does is it increases the tyrosine kinase activity, causing the multiplication of these cells, causing uncontrolled cell division, and that is the genesis of this malignancy. So the chronic phase is the majority of these cancer cells, majority of these cancers, and generally has a good prognosis. And once we go into the accelerated or blast crisis, the prognosis becomes bad. Now, so we've spoken about the diagnosis, we have spoken about the prognosis, and now about the treatment part. Now, chronic myeloid leukemia is one of the first hematological cancers treated without chemotherapy. Because previously, people were treated with chemotherapy, with all the side effects of the chemotherapy. Now we got a specific antidote. Basically, we got a drug called imatinib with the trade name called Gleevec. So this is a specific antidote. How does Gleevec work? This is a chart making it very simple. So, you know, in this BCR-ABL translocation, the cancer protein is synthesized, leading to the leukemia, the CML, and obviously you got the ATP, which is the power currency of the cell. So what the Gleevec does, it displaces or it competes with the ATP binding region, so thereby stopping the cell division. So this is how it helps. So you see, it's a a beautiful concept, and it works. So subsequently, a few words about minimal residual disease in chronic myeloid leukemia. So when we treat, now what we are interested is we want to remove the disease from its roots. At 3 months, we think there has to be a complete hematological remission. When we say about that, what it means is, the white cells have normalized, the spleen has come back to normal. Then subsequently, after that, we look for reduction in the metaphases, the Philadelphia metaphases. So over that year, ideally every 3 monthly, we have to check, and we want 0 metaphases at the end of the year, basically. And subsequently, we also do an BCR-ABL transcripts are checked. Now, when we say 0.1%, that's a logarithmic scale. Now, why was a logarithmic scale used is something I don't know. But basically, that is like a unit of measurement. It's like, when we say 1 gram or something, why was a gram used? We don't know really. So bottom line is, to make it simple, we need to follow it up. So that is what is useful. So we need to follow it up to ensure that the CML metaphases have completely been obliterated from the patient. So you can see, number one, we have made a diagnosis, we have made a prognostic implication, and we have treated, and then subsequently we have followed up. And because we know the cytogenetic treatment, cytogenetic changes, an antidote has been discovered, and now we got the 2nd generation drugs, we got the 3rd generation drugs. So we got a lot of additional drugs also for people who are progressing on the 1st generation. So any talk on hematological malignancy is incomplete without talking about this book. So this is the WHO classification book. And now, from a morphology, I did show you the peripheral smear picture of the chronic myeloid leukemia. So traditionally, all the diagnosis was based on morphology. How did the cell look like? So you got AML, M1, M2, M3, M4. And even now, many of our pathology colleagues, say, oh, this must be AML M5. Now, to me, AML M5 or M6, sometimes that's not really that useful. All I want to know is whether it's M3 or not. Because one thing is, it's a treatment implication, but since 2008, cytogenetics is part of diagnosis and classification for many hematological malignancies. So, classification of MDS patients, it is essential with the morphology. For the lymphoma, so also this is essential, and part of the prognostic stratification of multiple myeloma. So if you open the WHO book, all you see is cytogenetics. So this is the revised classification of acute myeloid leukemia. You look at that. Everything is AML with 821 translocations, AML with inversion 16, AML with PML RARA. So the entire book is replaced from morphology. We have gone to chromosomal translocations and FISH and molecular changes. So this is the future. We could say this is the present and this is the future, because each of these changes have both prognostic and treatment implications. So that is the reason for changing it. For example, the first few recurrent genetic abnormalities, 821, inversion 16, and PML RARA, so these have got a very good prognosis. So we can treat them with chemotherapy alone. But subsequently, you got FLT3 and other things which are bad prognosis, and there you need a bone marrow transplant. So that is the importance. You see, it is of fundamental importance to the clinician to make a diagnosis, to classify it, and also to treat it. So it is impossible in the modern era without karyotyping and all the molecular workup. So this is what I meant about prognosis. So you got the favorable group with 821 inversion 16, and then you got the adverse group. So I don't want to describe them all of them in detail, but so this karyotyping and FISH and our molecular studies would straight away make a diagnosis of the patient. So the old days of AML, M1, M2, all those things are outdated now. So next is, I spoke about prognosis. Now look at the survival. So the first one is translocation 15-17, which is acute promyelocytic leukemia. So look at the survival. So these patients, have survived. So this is part of the UK AML trial studies. Now, one thing I forgot to mention earlier was, one of the reasons, I ended up sending so many samples here was because of your PhD students also, because I can see Akamsha, Nagaraj and Shivani here. So anytime I have a leukemia patient, whether it is in Yanapoya or in the private sector also, I end up calling them, see, we have a new case. See, I have sort of participated in this trial, not as obviously I was only a PG in the UK at that time. So we were contributing, any leukemia comes, they would go to a clinical trial. I mean, obviously we would counsel the patient, we would say, we are giving you a conventional treatment or something with an additional drug, which may be based on the molecular change. So I have actually contributed to this particular trial. So all these UK trials, any disease, we immediately stratify patients in the trial. So that sort of comes automatically to me to provide a trial sample. And you can see here, this prognostic or number of overall survival of the patients is entirely based on the chromosomal changes. So this is the importance of karyotyping. Now I spoke about promyelocytic leukemia. So for a hematologist, this is how it looks like. You got a lot of these granules, you got these rods called OR rods. So this is what we see, and we make a diagnosis. So this condition is a hematological emergency. So if you don't recognize and treat promptly, the patient will die. So that is why I often end up calling Reshma and saying, see, I have sent a sample for PML RARA. How quickly can you get me the results? So again, we got a personalized touch with Nitte, and we get the results within 24 hours. So I'm very grateful for that. And this is again a condition whereby there is a differentiation block, which essentially means, in simple terms, the cells get arrested in the promyelocytic stage and they don't mature into normal cells, and there is a proliferation of promyelocytes and cancer blast cells. So again, we got treatment here. We have got all trans-retinoic acid, which will cause a differentiation of the cells. So this is again, we are treating based on the molecular changes. So the medicine has become molecular. So just a timeline. So promyelocytic leukemia was first described in 1957. Chemotherapy was used initially. 77, the lesion was identified, and then ATRA or oral trans-retinoic acid was tried in 87, and then the treatment was revolutionized. And now many of my low-risk patients, we treat them without chemotherapy. We give ATRA with another drug called arsenic trioxide. So this is entirely a non-chemotherapy. So, first thing patients ask is, will I lose my hair? I mean, I often wonder at that time, he's going to die without treatment. So why are you asking me whether he will lose my hair? Because we have to treat anyway. So then they ask what side effects. Then I'm thinking, okay, this man is going to die without treatment. What about side effects? But here we got a drug. I mean, there are some side effects, yes, but the most visible side effects are like hair loss and all those things. So bottom line, acute promyelocytic leukemia, we have to get the diagnosis quickly because without treatment, the patient will die, and first 2 weeks are quite critical. But once we start treatment, we can cure, and that is a good risk leukemia. So you see how it goes from a very dangerous type of leukemia to a leukemia that can be completely cured. So we need to get the diagnosis as soon as possible. Now, acute lymphoblastic leukemia, we have got Harsha Prasada, who is an expert in this area. So again, look at how it has become molecular. You got 922 translocation, hyperdiploidy, everything is there. So again, when we get an acute lymphoblastic leukemia patient, when we suspect that, obviously we make a diagnosis both morphologically and using flow cytometer. Then immediately I ask for the karyotyping, a sample which has automatically been sent, and then I call up Reshma and ask her, can you do the FISH panel? Again, that tells me how to treat. Suppose ALL can also have the Philadelphia positive, then of course I know I have to add the imatinib or Gleevec to this patient. So again, the prognosis, and that also helps me to determine whether a patient goes from intermediate risk to high risk. So all these things are very useful based on this. I think this is basically a distribution of cytogenetic abnormalities from data from the UK trials. So you got this thing, 2112 translocation, which is quite common, and then hyperdiploidy. This again another one of the same. So here again we are talking about precursor B, precursor ALL, and how these translocations are noticed or are diagnosed using our conventional karyotyping. So in acute lymphoblastic leukemia, for a diagnosis, classification, prognosis, and treatment decision, we need that. Going to myelodysplasia. Now, myelodysplasia is a sort of an abused terminology in the sense that it is not very easy to diagnose, because we get so many patients with anemia where it is not clear what is the cause of anemia, and sometimes we do so many tests and we still don't find out what is the cause of anemia. Sometimes we do a bone marrow and the morphology is not clear, and sometimes we may wonder whether we have done a bone marrow early, because there are certain descriptions in the morphology. When I mean descriptions, there are changes in the way a cell looks like, because in the nucleus there may be nuclear budding, nuclear duplication, all these things. So sometimes we may not pick up these changes, or changes may be subtle. But if you have sent a karyotyping sample, then we may pick up the typical chromosomal aberrations which are seen in myelodysplasia, and then you got a diagnosis. So this is the WHO classification based on the traditional classification based on the dysplasia and BLAS. So the chromosomal changes in myelodysplasia may be de novo, or it could be secondary MDS because of previous treatment or other. So it is basically it's a mirrored in heterogeneity of acquired genetic changes. So again, prognosis. This is a good slide showing all the prognostic changes. So if a patient with MDS is there, Now they ask me what is MDS, so it is very difficult to explain to the patient. Sometimes I tell the relatives it is somewhere in between a normal and malignant and leukemia, somewhere in between that, and patient may progress. So you look at the our conventional karyotyping results. So we got deletion L11Q. You look at the overall survival. It is 5 years. So this may be an 80-year-old patient. If you get something like this, then we don't really worry about. It's really a good thing. Whereas look at the opposite side. We got complex cytogenetics, more than 3 aberrations seen. So what is the median overall survival? Just around 6 months. So the story I would like to tell you is in UK. I still remember vividly. There was one elderly lady who had a very complex karyotype. And then she was asking me, doctor, what is my diagnosis? And I said, it is somewhere in between this thing. And then she made me draw a line. And she wanted me to tell, am I in this end or in the other end? So then I had to tell her she is near this end. So I don't want to go into details of this, but you see the prognostic classification. There's something called a prognostic scoring, which helps us to decide on whether it's a good, intermediate, or bad. And that also decides on what treatment we give, and also whether a patient needs a transplant. Because acute myelodysplasia with the poor prognosis, like in poor prognosis AML, requires a bone marrow transplant. So that is the treatment decision that is to be made using conventional karyotyping. So once again, diagnosis may be missed if you haven't sent a karyotyping. So many times, particularly with our general physicians, often I get upset when they do bone marrows because they don't send a karyotyping sample. And then doing another bone marrow is not a feasible thing at all. When you have got an unexplained anemia and you do a bone marrow, you have to send a karyotype sample. Now, talking about MDS would be incomplete if you don't talk about 5q deletion. Now, this is a different subentity by itself. This is because it has got a good prognosis, and also it responds to a drug called lenalidomide. So, lenalidomide helps in treating this condition, and patients respond. So you see, you picked up 5q minus, you got a treatment. So that's so wonderful there. Chronic lymphocytic leukemia. Again, let me jump straight into the overall survival category. So there is 13q deletion, which has got good prognosis, while you look at 17p deletion, the prognosis is really poor. So based on the genetic abnormality in chronic lymphocytic leukemia, we have decided on what is the overall survival of the patients. Now this is in spite of treatment. And if it is low risk in chronic lymphocytic leukemias, sometimes we don't treat the patient also. If the patient has got low risk and it is not causing any problems, sometimes we just watch and wait. Sometimes a 75-year-old man may die of some other causes, and there are specific criteria for treatment. So we may just sit and wait and watch. Of course, obviously for 17p and all, that is not a choice. This is again another one showing the mutational landscape of CLL. Now, we have talked about the the diagnosis and prognosis of the CLL. Now, if you are talking about the treatment, now, for example, TP53, which is 17p deletion, that does respond to certain drugs, BTK inhibitors and other things. So sometimes we use drugs called ibrutinib, and they respond well, at least initially. So again, you got tailored treatment. When at a tailored treatment, you got a chromosomal aberration, and you have taken a decision on the treatment. Again, you got the the prognostic scoring, you got the treatment. Speaking about non-Hodgkin lymphoma, again, it's a very heterogeneous condition. There are some 20-25 different types of non-Hodgkin lymphomas, but there are some common ones like diffuse large B lymphoma and also follicular lymphoma. Now, I still remember, as a PG, I used to forget, what is the chromosomal change in follicular lymphoma, what is mantle cell lymphoma. I wouldn't remember then. Then I had to think that, okay, it is 14-18, 4 for follicular. So that is how I used to remember, 4 for follicular, 14-18 translocation. So again, helpful. We got immunohistochemistry to make the diagnosis, but obviously this does help if you are making a bone marrow diagnosis. Now, mantle cell lymphoma, it's one of the aggressive lymphomas. Again, there is something called cyclin D1, so that is what is helpful in making the diagnosis. But again, many a time we do conventional cytogenetics, and the 11-14 helps us in making a diagnosis. So again, you see, in lymphoma also, if you're doing a bone marrow, you got to send a sample for karyotyping. So if you get this one, it helps us, because perhaps we may not need to do IHC, but I think in the modern medico-legal era, probably we wouldn't treat without doing an IHC, but that's helpful. Coming to Burkitt lymphoma. So Burkitt lymphoma is a very aggressive lymphoma. So how I remember about aggressive and non-aggressive lymphomas? Aggressive lymphomas, if you don't treat urgently, patient will die. But many of them are curable. Now, indolent or slow-growing lymphomas, we can sit on them for some time and nothing may happen, but very difficult to eradicate. So they may come back again and again and often. So Burkitt lymphoma is another aggressive lymphoma. Diagnosis is through immunohistochemistry, and even simple morphology helps us in the diagnosis. But you got your typical molecular changes. Usually this 8-14 translocation is helpful. There are a few other translocations also in that, and sometimes we do get a few complex karyotype along with the typical changes, and sometimes they are difficult to eradicate. So I think from Burkitt, let me jump to multiple myeloma. So multiple myeloma is a bone marrow cancer which affects the bones, kidneys, and also blood. Now, often there are mutational changes which lead to multiple, the progression of this disease. But I suppose what is useful is, see, there are so many translocations which are based on the chromosome 14, 16, sometimes 16, 20, inversion 1, and also TP53 in multiple myeloma. Now, these days, we don't take treatment decisions based on the myeloma fish. It's a standard treatment, but we do know that certain translocations with the 16 chromosome, they often respond well to bortezomib. But saying that it is anyway the first line treatment, there is also a type of multiple myeloma where we have 11-14 translocation, and a drug called venetoclax sometimes helps there. So again, You see, we take a treatment decision, we take a prognostic decision. Now, speaking about TP53, that has caused me a lot of difficulty. The only sort of, problem I had in the sense that it is, whatever you do, TP53 patients are difficult to cure, particularly in myeloma. So whenever I think about it, I do remember a very bad experience in the UK whereby one patient progressed despite treatment because he had TP53, and the family were very upset, and they put in a complaint saying that we didn't treat properly. And then I had this difficult job of writing a reply saying that we followed all the guidelines, but the disease was bad, and of course nothing came out of it because we did all the right things. But then see, this is again a bad prognostic marker, and it does impact on the survival. So summary, see, I think for a hematologist or an oncologist, it is essential to do conventional karyotyping, and often we need molecular and FISH results for diagnosis, prognostication and treatment of a patient. Now, despite everything, previously Harsha Prasad said, the conventional karyotyping is still necessary. So despite everything, we still have to do conventional karyotyping, and that I don't think will be replaced in the near future. Thank you very much.
Thank you, sir. The topic is open for discussion.
So if there are any questions from the audience, if there are none, I'll ask Dr. Rajesh myself. So that thank you for the talk. So you took us very nicely through the journey of CML, acute leukemia, and Burkitt's lymphoma, MDS. You touched upon every disease, myeloma as well. So do you think that we will be at any point of time going away from, you did mention in your last slide that conventional cytogenetics is here to stay. Do you think at any point of time in future, maybe 30, 40 years down the line, maybe, will it go out of favor?
See, if you look at anything in medicine, there have been progress, always there have been progression. So you look at classical clinical medicine, previously they did not have ultrasound or MRI scan, PET scan. So we have moved through them. So conventional karyotyping, I think may be done in a different way in future probably, like our Vice Chancellor was telling, with the artificial intelligence or something, maybe we may have to give one drop of blood and we may get the results of, so it may be done in a different way, but it is there to stay always, I think.
I agree with Dr. Rajesh. I'll just give one example. We had a case of acute myeloid leukemia in a 30-year-old woman, and we did all the NGS and all of that was done, and it came negative. But what actually helped us was, I think, Dr. Jairam Shetty may not remember this case. This patient had a 1621 translocation. This is very unusual. Even I didn't know at that point of time. I had to go back and search the literature. This was a very high risk for relapse actually, and this patient promptly relapsed after 2 months of completing the standard 3+7 plus 3 months of consolidation. So conventional cytogenetics is always here to stay. It will never go anywhere, even though we may get NGS or we may have a lot of gene therapy in the future. But cytogenetics is here to stay. We may get something which even this refined tests may not pick up. So I think it will stay even after 30 years.
It will stay.
So
That's
that is
what
my
I think.
take on it, because I think some things are, some older techniques will always be there to help us, and it is very cost effective.
Correct.
Where NGS costs thousands of rupees or lakhs, conventional cytogenetics in our hospital is hardly anything, on par with what they are doing in Vellore. So that is again kudos to the team. I think our cytogenetics is one of the best. And if there are no questions, I would like to close this session. Thank you. I think Dr. Jairam. Yeah. Yes.
One point that, any molecular studies, whenever you are looking for the marker, you are asking for some questions. So they will be looking in those DNA analysis, only those markers what you have recommended to look for. But here what happens, the variations what you see, variant form of translocations, that will never be picked up by molecular studies. I can assure of those things. Thank you.
So we also have similar clinical experience. So cytogenetics is here to stay. If students are interested in pursuing this field, please don't think that NGS will come and take these things away. Cytogenetics is here to stay, and it will not be a replacement for any of these modern tests. So thank you. Thank you.
Thank you, sir. As a token of our love and appreciation, may I request our chairperson to present a certificate of appreciation to Dr. Rajesh Krishna. Thank you, sir. May I now request Dr. Jairam S. Kadandale to present a certificate to our chairperson, Dr. Vijit Vittal Shetty. Thank you, sir. Moving on to the next talk for the day, which will be by virtual mode. It's on genetic counseling in cancer syndrome by Dr. Meenakshi Bhatt, consultant in clinical genetics, Center for Human Genetics, Bengaluru. The chairperson for the session is Dr. Prashant Naik, Associate Professor, Department of Pediatrics, K. Segde Medical Academy, Nitte DU. I request the chairperson to kindly occupy their seat. I request the chairperson to introduce the speaker.
Can you open your camera, ma'am?
Welcome, ma'am. So we have with us Dr. Meenakshi Bhatt, consultant in clinical genetics, Center for Human Genetics, Bengaluru. I request our chairperson, Dr. Prashant Naik, to introduce the speaker.
Good afternoon, ma'am. I am Dr. Prashant Naik. Welcome to the program. Identification of genetic basis underlying certain types of cancer has led to an increased demand for genetic counseling about individual risk of the diseases. As it is, counseling about the diagnosis of cancer itself is a very crucial subject, and when we have to tell the parents or the family members that there is a chance that okay they also may be having it, becomes all the more very tactfully it has to be managed. So for that talk, we have Dr. Meenakshi Bhatt, who will be talking about the genetic counseling in cancer syndromes. About Dr. Meenakshi Bhatt, she is a professor at the Center of Human Genetics and completed her medical graduation from Mysore University with first rank and 7 gold medals. She was awarded a gold medal for MD in Pediatrics from Mumbai University in 1992. She has a postgraduate degree in pediatrics from the DNB and diplomate in child health. She has pursued MRCP pediatrics in 1998 and a 4-year certificate of completion of specialist training in clinical genetics from Northwest London Hospital in 2003. She worked as a consultant in clinical genetics at Guy's and St. Thomas Hospital, London. Currently, she is working at Center for Human Genetics, Bengaluru, with clinical affiliations at Indira Gandhi Institute of Child Health and Bengaluru Fetal Medicine Center. Over the last 6 years, she has evaluated and counseled over 7,000 families with genetic conditions in India. Her special interests include clinical dysmorphology, syndromes associated with congenital heart disease, lysosomal storage disorders, and genetic counseling. She is also actively involved in teaching programs in medical genetics, which is funded by Department of Biotechnology and ICMR, for conducting recurring short teaching courses at Center for Genetics. And she has been a member of the DBT India Task Force on Human Genetics and Genomics, and more recently as member of ICMR National Task Force for Lysosomal Storage Disorders. I welcome you, madam. Over to you.
So, I hope everybody can hear me and see my screen also. Could somebody confirm that?
Yes, ma'am.
Yeah, okay. So good afternoon, everybody. I'm sorry that I'm not amongst you, but I'd like to thank the organizers for having me here. I know that the program so far has been talking about how do you interpret a report with regard to cytogenetic abnormalities and cancers. But I think the most important part of everything is that at the end of the sample, there's a human being. And whenever we have human beings that have got such dreaded issues, it's really trying to find out what exactly is happening with them and how do we explain to individuals the composite of the reports and what is the illness like and what the prognosis is based on all our advanced technologies. So I'm just going to give you a few examples of childhood and adult conditions and how they are related to, we are not just talking about somatic alterations, but we are talking about genomic alterations in the blood that you're likely to see with regards to inheritance patterns. So this is the type of people that come into our clinic, and this is not how it should be. But here are two daughters of a consanguineous couple who have, as you can see, very, very disordered skin. And wherever you see the yellowish marks on their faces, they actually have started to develop localized basal cell carcinoma. Now, whenever you have lesions like this, recognition of the condition is not very difficult, but it just shows you an extreme degree of what has happened. The moment you have two girls who are affected within the same family and the parents being normal, you can almost begin to suspect that this must be autosomal recessive inheritance pattern because the parents are fine, and in this case the parents were consanguineously married. Now, this is a condition known as xeroderma pigmentosum, and there are many subtypes, and this is supposed to be exceedingly rare according to the Western publications. But in our country, and especially in southern parts of India, we see quite a lot of this, almost 1 every 3 months or so. So as I alluded to before, it is autosomal recessive inheritance, and these are malignancies that are induced in people that have DNA repair defects by sunlight and UV rays in particular. They can have many changes in the skin that is exposed to the sun, malignant melanomas, basal cell carcinoma, and squamous cell carcinoma. And the underlying defect is a genetically induced impairment of DNA repair. There are several such syndromes, and I'm going to show you one more, which is a little bit more subtle. So these are eyes of two different siblings, a male and a female, who were fine when they were born, but as they started growing up, they had this persistent redness which was seen on the white part, the sclera of the eye. And in addition to that, these children had started becoming progressively unsteady with a tendency to fall, especially forwards. One of the children, who was a little older, had recurrent infections, just colds, coughs, kept coming into hospital, getting treated with antibiotics. And this is the recognition factor. If you see eyes like this, and if you know that this has been persistently present, this is what we call ataxia telangiectasia. It's a big name, ataxia, because the central nervous system is affected, especially the cerebellum, and telangiectasia is actually prominence of the small capillaries, which can be seen most prominently on the sclera of the eye, but can also be seen on various areas where the skin is thin, behind the ears, on the cheeks, and elsewhere in the body. It starts appearing between 3 to 5 years of age, and the ataxia can precede it. Now, the problem over here is that there is progressive cerebellar signs and telangiectasia, which we have spoken to, and the recurrent infections. The IgA levels are grossly reduced, which makes them very prone to localized infections of the respiratory and the GI tract, and AFP levels are elevated. This is also a chromosome breakage or a DNA repair defect and can be easily identified on a blood sample. And like the previous defect, it's also an autosomal recessive inheritance pattern. Sadly, there is no treatment for this condition that can actually reverse the entire process, and they are very prone to leukemias and lymphomas, and these do not respond very well to therapy. So I think before we start being aggressive about treating all leukemias and lymphomas as the same pattern, it's important to look out for the very visible, simple things that if you look at a family history and clinical examination should be easy to pick up. So in this case also there is another factor. Mothers who are carriers of this condition have got a proneness to develop breast cancer as they grow older. So it's something that you can introduce screening into if you know that ataxia telangiectasia is the cause in the child concerned. Now this is mitomycin-induced chromosome breakage. Wherever there are light blue arrows, you can see that there are multiple chromosome breaks, either of the single strand or both strands. And this is induced in the lab. This is, you've just heard Professor Jairam speak in the beginning. And this is his lab that does all these investigations for these kind of syndromes. And both in ataxia and in xeroderma pigmentosum and half a dozen other conditions, we have these chromosome breakages, which is the first step in identifying that there is a problem, after which you can go on to do confirmatory mutation testing in these individuals. And this is one of the more commoner conditions that we see, which is Fanconi syndrome. I'm sure all of you have heard about Fanconi pancytopenia, but when you look at clinical examination, there are children that are born without thumbs in one or both hands, or they may have alteration of shape of the thumbs, which may be either hypoplastic, they may be underdeveloped, or they may just have an altered shape. And this is a very subtle thing that we need to look out for in case you see this kind of sign in a child that has got chromosome breakage, then you know that this is likely to be Fanconi's pancytopenia. If you look at the skin, they have an increased number of cafe au lait patches. They're smaller and shorter than other children, and they come to the clinic because they have usually developed pancytopenia. So low levels of all three blood series, and sometimes when you do the bone marrow, it reflects aplastic blood picture. So you usually need a refined biopsy rather than an aspiration. So raindrop pigmentation to start off with, and then you start having this kind of skin manifestations. In addition to the skin breakages that we showed in the first slide of cytogenetic spread, you also get these very unusual manifestations or presentations, which are called the triradials and the quadriradials, which are very typical for Fanconi pancytopenia, and they help you diagnose this condition. Again, under Fanconi's, there are many subtypes, and this is a complement pathway alteration. So you really need to establish it by mutation testing once you've got breakage syndrome. One type of Fanconi is caused by BRCA2, which is the breast cancer 2 gene, and this can present with hypoplastic thumbs, short stature, aplastic anemia in the child, but then the mother will be prone to breast cancer, or the father may be prone to pancreatic or prostatic cancer. And we need to be aware of these things when we are advising the family about how to look. So really what I'm trying to say is that we need to look beyond the individual and look at the wider family to see what is really happening in the family and what is the implication for the family once you make a diagnosis before you start treatment. What causes all these things? That there is a highest level of consanguinity, especially in the southern part of India. Karnataka, in the recent National Health Family Survey, had a 28% chance of having close consanguinity within parents who are married. So almost 1 in 4 couples has got either an uncle, niece, or a first cousin or a second cousin marriage. Not only does it increase the chance of having autosomal recessive disorders to twice that of the general population, it also predisposes to these rare cancer syndromes, which manifest as multiple findings beyond leukemia, lymphoma, and other such malignancies, which we need to rule out as we go on examining parents. And of course, when you look backwards in the family, you really need to trace back the carriers, because many of them may be prone to different disorders beyond the individual that has come to clinic to be treated for leukemias. Now, I just wanted to give you an example because I know that at some point today people must have talked about leukemias, and in particular myelocytic leukemias. This is a small child. On the left side, this was the child when he was 1 month old, and this is when he's 3.5 years old, the same child. So when he was 1 month old, he had been referred to the genetic clinic as being slightly dysmorphic. For most people in the audience, they would feel that this child looks fine. But if you notice with the child's eyes closed, he has slightly down slanting eyes. And when you look at his ears, these are genuinely low set ears. So if you trace back a line from beyond the eyes, you'll see that that line is not cutting the ear as we usually find, but the ear is right behind and posteriorly rotated. Also, the child had widely spaced nipples, and he had a pulmonary stenosis. Now, this was the warning sign that we could see. His birth weight had been 2.2 kgs at term, and that's little lower on the lower than average. But the reason why he came to us is he had a very large spleen, and his blood picture and his bone marrow picture suggested that he had juvenile myelomonocytic leukemia. Now, this sounded like a terrible prognosis, but with our experience of looking at this condition, and as the child grows older, this is actually Noonan syndrome. So when you have Noonan syndrome, which is caused by a heterozygous mutation in any of the RAS/MAP kinase pathway genes, particularly in the PTPN11 gene, then sometimes in about 2 to 3% of cases, you can have this JMML picture, and you really don't need to treat them. You keep them under observation, do not start any aggressive therapy. And so we did, and this is the child at 3 years, and he's now 8 years old and is doing fine. We did absolutely nothing. What we did was actually confirm the fact that this was a PTPN11 mutation causing Noonan syndrome. Now, we have published from our center 106 cases with Noonan syndrome with PTPN11 mutation, and these are some of the children at various ages. Their face is usually round. They always have droopy eyelids. They look like they're almost sleepy. It may be in one eye like in this child, or both eyes as in this child, and they continue to look like this right through life. And as I said before, they all have low set posteriorly rotated ears. They have a lot of other things, but many of them have congenital heart disease, and it's usually either pulmonary stenosis, central or branch pulmonary stenosis. And they are short statured. So in this sort of a setting, if you see a picture that shows a myeloid type of blood picture, this is the bone marrow from the child that I spoke about. And we also ended up doing BCR-able testing, which, as you can see the discrete signals. So this was an unaffected report. And it helped us decide that we would not do any treatment, and we advised our colleagues in Kidwai that they did not need to treat. And there are many implications of making a syndrome diagnosis. So I just wanted to give you one such example on how important it is to look at a human being in toto before we actually start applying treatments and signifying the prognosis of a medical condition. So Noonan syndrome, as I said, was from the RAS/MAP kinase pathway, and these are oncogenic genes which actually cause multiple genes. So down in the pathway we have melanomas, and up here is where you have the Noonan syndrome spectrum. And if you look a little bit laterally, you also have neurofibromatosis type 1, which is a neurocutaneous condition. But there are other syndromes also. So there's Noonan syndrome. There are other Noonan-like syndromes which cause Costello and CFC syndrome, or cardiofasciocutaneous syndrome, the NF1, the Leopard syndrome. So there are many such things that are in the same pathway, and each one of these conditions is a precancerous condition and needs to be followed up in the long term for the cancers that they may develop. Now, this was a boy who had come to us as a cardiac patient. He had congenital heart disease. He looks, although he was very much from India, he has a slightly African type of appearance to him. He was short-statured. He had short, curly hair. He was of low normal intelligence, but what you can see around his mouth were these pimply little papular lesions, which were persistent and continuous. And there was some pigmentation at the back of his neck. And this is the typical presentation of Costello syndrome, which is also in the RAS-MAP kinase pathway. So Costello syndrome has a lifetime risk of 15% of developing malignancies, which could be variable and difficult to treat. Rhabdomyosarcomas, neuroblastomas, bladder tumors, and there is a screening program that is available to see that there is early pickup and therefore better prognosis for these. And the vast majority of them have a mutation in one of the genes in the same pathway called HRAS. As you know, HRAS and KRAS, if it is somatic mutations, they are determinants of therapy also, but this is a germline mutation. And one of the real pickup points is either the perioral or the perianal papular lesions which come up in a child that has Costello syndrome. So it is possible to prognosticate on different cancers if we are able to spend a little bit of time to look at any feature that may be unusual in the appearance of an individual. Now, all these conditions that are coming up, including whether we look at Costello syndrome or other syndromes, we spoke before of the Brackett syndromes, which were autosomal recessive. Some of these Noonan syndrome and Noonan-like syndromes are inherited in an autosomal dominant trait. So if you have an affected individual, even having one heterozygous mutation or a dominant mutation causes them to be at risk of developing cancers, but also they have a 1 in 2 chance of having an affected child, male or female, who inherits the same gene and may have a lifetime risk of various cancers. We need to be aware of this because increasingly parents are asking us whether we can do something for them in prenatal testing. Whether we should be doing, should not be doing is another ethical question. So in autosomal dominant inheritance patterns, we see pedigrees like this, where you have every generation having some degree of involvement, either the facial manifestations or the medical complications or the malignancies or some this thing. So this is why it's very important to take at least as a minimum in the clinic a 3-generation pedigree, because you can identify whether there's a 50% chance that it's going down from generation to generation. And with regard to many of these malignancy conditions, there are no skip generations. There is a manifestation in almost every generation. And of course, you can see both males and females equally affected if you take a large enough pedigree. So it's important that the pedigree will actually point out to us whether there's a higher chance of there being a particular type of cancer. Now, when we examine people that do not have cancers, sometimes you can actually allude to cancers. This is the typical NF1 picture, neurofibromatosis type 1, where people who are much younger, that's 0 to 10 years, may only manifest with multiple cafe au lait coffee-colored patches. And this may be on areas that are exposed to the skin or maybe only on the back. And this is why it's important to examine the person in total from top to bottom. If you see cafe au lait patches, they may then go on to develop the neurofibromas or the lumps, which are much easier to recognize. But it is also in the same pathway, and what we really need to be worried about is that they are predisposed to multiple cancers. These could be either benign tumors like optic gliomas or the nerve sheath tumors, which may happen, or astrocytomas in the brain. Now, they're also very prone to leukemia. At least 2 out of 3 leukemias diagnosed in a child with NF1 turn out to be myeloid in nature. And JMML, which seems to be a recurring story from the RAS-MAP kinase pathway, is a RAS-driven malignancy and is 200 to 500-fold higher in patients with NF1 as compared to the general population. Like the story that I said about chromosome breakage syndromes, women who are carriers of the NF1 mutation are also predisposed to developing breast cancer at a certain stage. So it's very important for us to look at the patients, and I think I'm laboring the fact over here many times through our examples. Now, completely aside from that, when we're looking at pediatric age groups and we do just chromosome analysis, one fine day we looked at a child who had a ring chromosome 13, and as you can see, this has been picked up both, you can see it here and you can see it here. And when we went back to the child, and this is only a representative picture, we had this child screened for its eyes because, as you are aware, on chromosome 13 you have the RB1 gene. So when we looked at the back of this 5-month-old child, there was a really small, discrete tumor, and because we picked it up early, it could be lasered and the child has been normal under follow-up for several years. But sometimes the children, they present with what we call the white reflex of the eye. When you shine a light, instead of having a pupillary dilatation and a dark shadow, you may just get a white shadow at the back of the eye, and this is when ophthalmologists start looking more deeply at the fundus to see whether there's a growth of a tumor on the back of the eye. So we went in the reverse way. We found a ring chromosome 13, and that area probably included the RB1 gene, and we were able to pick this up. So what do we know about retinoblastoma? We know that it's an early childhood cancer, that it can affect about 1 in 15 to 20,000 children. This was the tumor in which the Knudson's hypothesis was first proposed. We know that there's always, if you look back in the family history, you might have a 10 to 15% chance of finding a family history. The majority of cancers are detected or happen under 3 years of age. It starts very subtly at the back of the eye, but once it envelops the whole eye, you can have this mass growing out of the eye globe, and it reduces and removes vision completely, but also spreads by blood very, very quickly to other parts of the body. In 2/3 of individuals, it only affects one eye, and in about 1/3 of cases, it can affect both eyes. In all individuals that have bilateral eye involvement, you can be rest assured that you will find a germline mutation in the RB1 gene or a deletion that includes the RB1 gene. People who have the RB1 gene in a blood test have a 50% chance of sending it down to the offspring. So it's very important that we look for this. If there's an individual with retinoblastoma, it's important that we screen the family. Now, coming to another tumor completely, which comes from diagnosing a syndrome. This is a syndrome that most pediatricians would be familiar with. It's called Beckwith-Wiedemann syndrome. There are 3 components to it. They're born with a huge tongue which doesn't fit back into the mouth. So that's macroglossia. They're born with a large birth weight. This was a difficult delivery. So there's Erb's palsy that has been created, and there's an umbilical hernia in the child. This triad of a large size, large tongue, and having umbilical hernia or omphalocele, it alludes to this methylation condition called Beckwith-Wiedemann syndrome. Once you see children with Beckwith-Wiedemann syndrome, they are more prone to develop a particular renal carcinoma known as Wilms tumor. And when you look at the Wilms tumor, it can affect almost entire parts of the kidney, and it's usually associated with hemihypertrophy of the body on the same part. Sometimes what happens is beyond on the chromosome 11, which causes Beckwith-Wiedemann syndrome, there might be a microdeletion, and these microdeletions include the genes that are involved in development of the gonads. It can cause horseshoe-shaped kidneys and development of the tumor. It's very important that we investigate these children very carefully when you have a mass, because even by ordinary diagnostic radiation, it may aggravate the tumor. So we have to be very careful, and if you pick it up early or if you're suspecting it early, its response to therapy is excellent with 90% 5-year survival rates. So it's important to know that these syndromes can cause particular cancers. Look out for them, and this screening is very simple. What we do is under the age of 8, we do 3 monthly ultrasound of the abdomen. That's all you need to do. So it's a very non-invasive kind of testing, but you can pick it up easily. There are other familial renal tumors. Renal tumors are difficult to pick up. So either it can be part of the Vagus syndrome with the microdeletion of chromosome 11p. It can be with the Beckwith-Wiedemann syndrome. It can happen as a part of von Hippel-Lindau syndrome, which causes other malignancies also. It can be a part of tuberous sclerosis and MET gene. All these are autosomal dominant conditions and need to be followed through the family to see whether it's happening within other family members also. Now, if we look at the inherited later onset cancer syndromes, all the ones that I described so far are the ones that are affecting children. Now, there are things that could affect children, but mostly adults. And what we know is that breast and ovarian cancers can run in families. You can have certain parts of colon cancers, which can be either familial adenomatous polyposis, or FAP for short, or hereditary non-polyposis cancers, or HNPCC. And the typical pedigree looks like this, with an autosomal dominant pattern, generation after generation that's affected. In this particular pedigree, you can see it's mostly women, but please, be aware that even men can be affected with different types of cancers. And this is some of the examples. So when do you suspect it? Is the histology different? Is anything else different? No, it's the same sort of breast cancer or the same sort of ovarian cancer that you see with sporadic issues. But 5 to 10% of what we think is a sporadic cancer may be caused by a predisposition gene, which is either BRCA1 or BRCA2, which account for the majority of cancers. Now, when do you suspect it clinically? You suspect it if the first malignancy, either the breast or the ovarian cancer, starts before 50 years of age. It should ring warning bells in the clinician who's seeing the family. Or if there are recurrent primary tumors in the same person at the same time or after adequate therapy. So you get breast cancer cured in one breast, but then you go on to develop an ovarian cancer. This is almost certainly going to turn out to be a genetic form. If you have multiple first degree relatives, mother and daughter, aunt, two sisters, aunt and niece, these are things that we need to look out for with similar types of cancers. Or if a male develops breast cancer. So it's very unusual for men to develop breast cancer because there's very little fibrofatty tissue that is around the breast region. But even men can develop if there is a predisposition gene. And of course, if on histology you have a triple negative breast cancer, which means that you lack receptors for estrogen, progesterone, and HER2. So these are the conditions which may be breast cancer predisposition genes that may be there in the family. And the commonest breast cancer predisposition genes, BRCA1 and 2, in 5 to 10% of breast cancers and in 10 to 15% of ovarian cancers, it may be caused by one of these two genes. And a woman who's been detected to have a BRCA1 mutation has a lifetime risk of 85% of developing breast cancer. So there are many, many implications to the breast cancer genes, and men who do not develop breast cancer, they may develop early onset prostate cancer, and in some cases, they may develop colon cancers. So we need to be aware of these things because, again, they are autosomal dominant in nature. What about the inherited colon cancer syndromes, whether it's HNPCC, which is otherwise known as Lynch syndrome, or the familial adenomatous polyposis? Each of these topics is a talk by itself, and I'm not going to go into details, but what I would like to say is that about 5% of all colon cancers have an inherited autosomal dominant gene. And if you're at familial risk, so if you've got a first degree relative who has one of these inherited colon cancers, then your own risk goes up to 10 to 20% of developing a cancer like this in the colon. Now, there are new studies that are showing that low dose aspirin prophylaxis may reduce the chance of such a thing happening. So in combination with a high fiber diet and low dose aspirin, it might be possible to actually stave off this breast colon cancer risks that are caused by the HNPCC genes. There are multiple genes that can cause HNPCC, and they are MLH1, MSH2, MSH6 genes, which are the commonest causative factors. However, if you look at familial adenomatous polyposis, it's a completely different setting. It's caused by the APC gene. What happens is, in a child that's aged between 10 and 12 years, the colon develops hundreds to thousands of polyps or little pouch-like outgrowths into the intestine, and these are seen along the length, from extending anywhere from the end of the esophagus all the way up to the rectum. Most of them are benign when they start off, but one or more can become malignant over a period of time, and by 40 years of age, almost certainly one or more of these polyps would have become widely an adenocarcinoma. So what the prophylaxis to this is that you start monitoring these children from the earliest time that you see multiple polyps. You do the gene testing in extended family members, and you do as much surgery as that person can tolerate. So you usually remove the small and large intestine, and you have to look after the nutritive components of what is lacking as a result. B12 absorption and absorption of several other elements get affected. So these are some of the things, the implications of individuals that have inherited cancers and how to look at them. What do we do when we find out anything that is happening? First of all, the families are completely distraught. When you know that you're at 50% risk of a cancer, it makes you thinking completely, it really takes the carpet away from underneath your feet. So what do you do when you have to test children for cancer predisposition syndromes? You usually do not test children unless they are at risk of developing the cancer in the childhood groups. So Breakage syndromes you'll test, but adult predisposition cancers you do not test in children. Predictive testing. Suppose you have your mother who's developed breast cancer and you know she has BRCA1, and you know that you are at 50% risk of inheriting the same gene. When somebody like that comes to clinic, you have to be very careful to see that you're not you offer the test immediately, because the person is probably coming to you to know that they don't carry the gene, but there's a 50-50 chance that they do carry the gene. And knowing that you're carrying a gene that puts you at lifetime risk of 85% of developing cancer can be very psychologically debilitating. So they need a lot of counseling before they take up the test. The questions that people ask is, what if my baby gets it? Can I test for it in pregnancy? Is it ethical to test for something that may develop 30 or 40 years later, especially when you can't do anything about it? Is it ethical to not offer the test if the family demands it? So these are not answered questions yet. If you have a cancer gene and you don't declare it for insurance, all your premiums go up and you're not covered for some of these malignancy treatments. You need to be aware of it before insurance is taken. And of course, if there are various family members all at 50% risk, do you share the results between that one sister has it, one sister doesn't? You have to treat each family member as an individual and not share results or see them in mass. So they may choose to share results with each other, but each individual has to be treated individually. And what we do is we take pedigrees in very great detail. Yesterday itself at Timkur, I was seeing a family. It took me 1.5 hours to take a colon cancer family history, because every little abdominal complaint needs to be taken into issue. So it establishes rapport with the family. You learn a little bit more about the family. If you see multiple affected people, then you know that there is an inheritance pattern that you can recognize. It helps in predicting genetic risk to different individuals in the extended family. You can advise about prophylactic screening strategies. You can identify other unmentioned disorders which Can you hear me?
Yes, ma'am.
So there was only one slide left that I needed to say, and that was about genetic counseling. So genetic counseling is very straightforward. It's really addressing the issues that the family has. You explain about the condition, about the malignancies, about the surveillance, the inheritance pattern, the therapeutic options. Of course, the oncologists do this. We just go over the prognosis that is expected, the recurrence risk and future reproductive options, the information about support groups when they feel very isolated, and for pregnancy-related or other extended family members that need to be seen, and follow-up of these individuals. So that is how cancer counseling is done, and thank you for your attention. If there are any questions, I'm happy to take that. I can't hear anybody, but I'll assume that there are no questions, or if the software person can put it in the chat box, I'm happy to take it too.
Thank you, madam, for a wonderful talk, and especially highlighting the fact that.
So if there's nothing, I'll assume that it's close to lunchtime and that everybody is ready for lunch.
Hello.
Yeah. Dr. Prashant, I can see your hand up there.
Yeah. Thank you, ma'am, for highlighting the fact that many of the some of the cancers, a large number of cancers are genetically inherited. So it is important to have a genetic diagnosis, especially for the prognostication purpose, and also to prevent, especially if it's other family members also at a risk of this one having a.
Can your IT person just let me know whether there is anything, or I'm happy to log off?
Can you hear me?
I can't hear you people.
Hello, I'll talk on phone, ma'am.
Okay.
Ma'am, thank you for enlightening us on the importance of examination, especially in children, with treatment to see whether they have any genetic predisposition, and also about telling that how important genetic counseling. I'll ask if anybody has any question. I have one question for you, madam.
Yes.
When to do the
Delegates kindly maintain silence.
Like when somebody is diagnosed with cancer, with CFS, and she's diagnosed to have BRCA1 mutation, when are they going
Actually, that's a very good question. I hope you can hear me. So when do you in a family actually start looking for family counseling? So I think it's important that when the individual is undergoing intensive therapy, either surgery or chemo, it may not be the best time to meet the family. But as you do the genetic testing, which is usually done after the acute illness is over. And we must remember not to keep it too late, because we don't know the outcome of the individual, and you may lose an opportunity to identify the gene causing the problem. So if you have done genetic testing in the index case, then you need to be aware that you can actually see the family anytime afterwards. That is usually initiated by the family. So you make them aware that you would like to meet people who are sisters and daughters of the family member that is affected, and then bring them in individually. So give them separate, even if 3 people ring you up together and say, I need to come, you meet them one at a time in individual appointments. So there are no fixed time, but not during the acute illness of the index case.
Okay, thank you, ma'am.
Yeah.
And other thing I want to ask, any questions? Thank you, ma'am. Just wanted to ask, like, after we do the counseling, like after counseling, like post counseling, are there any how have we done any study on how it changes their affective domain as well as the behavior of the patient families? Like when we counsel the families, like after going home, how many opt for the test, how many deny for of the fact that they may be having a chance of getting a cancer? So, like.
Yeah, so usually if my mother has breast cancer, my knee-jerk reaction if I have an immediate relative is to go and find out whether I'll get it. So when they come for counseling, all of them come in thinking I'm going to give my blood test, I'll know a yes, no, and I'll go back home. But what we do is we spend at least 2 sessions counseling them and refuse to take the blood. This is international guidelines of pre-test counseling, where you ask them to go back and think about the implications. And there are well-published reports to say that only about 7 to 8% of women who first came to you for getting a test done pre-symptomatically, people who didn't have cancer but are at 50 or 25% risk of developing it because of a family history. Only about 7 to 8% of them come in for testing. They prefer not to have the testing. And for these women, it's important that whether they have the test or not, you put them as presumed carriers for screening. So you don't ignore them or send them away and forget about them, but you get them under screening.
Thank you, ma'am. Thank you. Okay. Thank you, ma'am.
Any questions from the
Any other questions?
audience?
Any questions from audience? Anyone? One minute, madam is coming.
Meenakshi?
Yes.
Yeah, if you agree, I will take your certificate on behalf of you.
Thank you very much. I'll be fine with that. Yes.
I request our chairperson, Dr. Prashant Naik, to hand over the certificate and memento to Dr. Jairam S. Kadandale on behalf of Dr. Meenakshi Bhatt.
Thank you. Yeah. Thank you very much. And I hope you found it useful, because I know this was very different from the heading of the whole seminar program.
We are extremely delighted with your virtual presence and enlightening talk, ma'am. It was a very informative talk. Thank you once again.
Thank you. And I can log out now?
Yes, ma'am, yes.
Yeah, thank you.
May I now request Dr. Sucheta Kumari N to present a certificate to our chairperson, Dr. Prashant Naik. Welcome back. But before beginning with the talk, I would like to share some important points on how to receive the certificates. So the certificate of the CMV will be sent to your registered email IDs. To receive the certificates, filling in the feedback form is mandatory, which will be again sent to your registered email IDs. This feedback link will be valid up to 24 hours. Another point that is to be noted while filling the feedback is to clearly mention your name and your institution, as the same will be reflected in your e-certificates. So hoping that you're clear with the issue of the certificate. So any queries or request of the certificates after or other than the aforementioned points will not be entertained by the organizing committee. Thank you for your patient listening. Moving on with the last talk for the day on melanthon-induced leukemia, molecular mechanism by Dr. H.P. Gurushankara, Assistant Professor, Department of Zoology, Central University of Kerala. I request our chairperson for the talk, Dr. Sucheta Kumari N, Professor, Principal Scientific Officer, Central Research Laboratory, KSECD Medical Academy, Nitte DU, to introduce our speaker.
Good afternoon to everyone. Here we are introducing our last speaker and our Dr. H.P. Gurushankar. He is a well-known person to us. Dr. Gurushankar did his MSc in zoology from the University of Mysore and obtained his PhD from Kuvempu University, Karnataka. He served as faculty in the Department of Environmental Science at Coimbatore University and the Department of Bioscience at the University of Mysore. His postdoctoral research at the University of Mysore and the Indian Institute of Science, Bangalore. He worked as coordinator at Talent Development Center, Indian Institute of Science, Bangalore. He has been working in the Department of Zoology at the Central University Lab, University of Kerala since its inception, 2010. He teaches cell and molecular biology, genetics, immunology, translational immunology, basic neurobiology and toxicology to MSc Zoology and also School of Biological Science student. He is also offering a skill-based course on genetic disease diagnosis. Dr. Gurushankar is an external examiner for PG and PhD thesis in various Indian universities. He is instrumental in designing the course curriculum for zoology. Dr. Gurushankar is guiding 2 PhD at present and already guided 2 PhD students and more than 50 MSc dissertation. He has published more than 30 research papers in international and national journals. He has authored the book and Understanding in Cytogenetic Techniques, his scientific articles in the Kannada Encyclopedia and books. Dr. Gurushankar is a scientific reviewer for many scholar national and international journal and project proposals. He is a life member for many associations, namely Biomedical Science, Indian Science Congress, Environmental Metagenic Society, and etc. Gurushankar has organized many national and international scientific meetings. He was invited to give a lecture at many scientific meetings, colleges, workshops, refresh courses, UG, DBT, DST, funded his projects. He has research collaboration with the Indian Institute of Science at the Central University, Karnataka and other premier institutions. Gurushankar research interests include the development neuroprotective strategies against Alzheimer's disease, antimicrobial and anti-cancer activity of peptides and autism spectrum disorder. Gurushankar sir, we welcome you and over to you.
Thank you. Good afternoon to all. Now I am standing after lunch. It's a very difficult to speak and convince the audience after lunch and before lunch. Before lunch you are all hungry, you are unable to concentrate. Then after lunch your serotonin level is going to be reduced. Then automatically you will be sleeping. Okay. Thanks to Rasmi madam and Sucheta Kumari madam and Prasant Sethi sir. Jairam sir, I am so glad, speak in front of Jairam sir. He is one of the renowned cytogenetist in the India, #1 cytogenetist in the India. We are having only, I think you have to be clear, we are having only 3 cytogenetics lab in India. #1 is Center for Human Genetics. He is heading that one. He is a director of that center. And another, he is also affiliated to our Nitte University. Our Suchet Kumari madam and Prasant sir is heading this one. Along with that, e-consultant. Then Gangaram Hospital, I think in Delhi, and Pune Actric. These are the 3 major cytogenetics labs in India. In that, the #1 consultant is our Jairam sir. Okay, we are if you see our niche or nest means where we came from. That is, you can take your Jairam sir or me or Sucheta Kumari madam or Prasant Sethi. We are all came from Mysore University. That is giving some touch to the cytogenetics. We are learned there. We started our learning from Mysore University. That still we are having that legacy of learning and we are spreading and we are contributing to the society. The best example is our Jairam sir, Prasant Setti sir and Sucheta Kumari madam, they are contributed lot to the genetics, particularly cytogenetic techniques. Then same thing, same knowledge, is transferred to our Reshma madam. That is the one, Thank you all for inviting me. I promise you I am not going to make you to sleep. I will give you some message end of my talk. I hope you will appreciate in the end. Okay, before that, I will show you one video, just 5 minutes video. Then, yeah. Yes.
Indian Academy of Biomedical Sciences, IABS. IABS was established in order to promote translational research for human health and well-being. The Academy is registered under Societies Act 1860 of Government of India. The initiative to form the Academy was taken by Professor Hari S. Sharma of University Medical Center, Rotterdam, Netherlands, who has been a great friend of India, organizing international conferences and promoting international cooperation with Indian institutions. Professor Sharma discussed the details with Professor Abbas Ali Mahdi in 2011 during his visit to King George's Medical University, Lucknow. Thereafter, Professor Mahdi got the Academy registered on 7th February 2012 and established their headquarters of IABS at Lucknow. The main objective of the Academy is to disseminate knowledge and academic excellence in the field of biomedical sciences by bringing basic scientists and clinicians on a common platform. It is hoped that the achievements and aspirations of IABS in promoting cutting-edge biomedical research will be attained with the vision, keen interest, and efforts of several scientists involved from India and abroad. The first conference of the Academy was organized at Lucknow by Professor Abbas Ali Mahdi, and it was inaugurated by the then Vice Chancellor of King George's Medical University, Professor D.K. Gupta, in presence of Padma Shri Professor Mehdi Hassan, who was the founder patron of the Academy. Professor Hari S. Sharma is the founder president of the Academy. Thereafter, once again, second annual conference of the Academy was organized at King George's Medical University by Professor Abbas Ali Mahdi. The third annual conference of the Academy was organized by Professor Najmul Islam at Aligarh Muslim University, which was attended by a large number of delegates from India and abroad. The fourth annual conference of the Academy was organized by Professor Vijay K. Kutala at Nizam's Institute of Medical Sciences, Hyderabad, which was again very successful, being attended by a large number of Indian and foreign delegates. The fifth annual conference of the Academy was organized by late Dr. Arun Raizada at India Habitat Center, New Delhi. And it was graced by the then Union Minister Dr. Harshvardhan and Padma Bhushan Professor Naresh Trehan, who was awarded the first Padma Shri Professor Mehdi Hassan Award during the inaugural function of the conference. The sixth annual conference of the Academy was inaugurated at a glittering function at Bhavnagar, and the conference was organized under the leadership of Professor Hari Om Sharma and Professor Jigna Shah. The seventh annual conference of the Academy was organized in April 2018 in beautiful and picturesque Kashmir Valley's Sher-e-Kashmir International Conference Center at Srinagar by Professor S. Mudassar. The 8th annual conference of the Academy was organized by Dr. K. G. Raghu at NIIST Trivandrum. And the 9th annual conference of the Academy was hosted at D.Y. Patil Institute of Medical Sciences, Kolhapur, Maharashtra, and Professor Bipin Tiwale was the organizing secretary of the event. During the Kolhapur conference, for the first time, convocation of the Academy was also held, in which awards and fellowships were given to the esteemed recipients. The Academy also organized a number of mini-symposia and conferences for the benefit of students in different parts of the country, be it at Government Medical College Jammu, hosted by Professor A.S. Bhatia, as also in parts of the country, be it Mumbai, Aligarh, Lucknow, Ahmedabad, Pune, Agra, Pondicherry, Coimbatore, etc. The Academy has instituted numerous awards to recognize and promote talent at every level. Awards in various categories for senior, middle level and junior faculty and budding scientists, as also students, are given every year to endorse academic excellence. Some of the notable recipients of the Academy Awards include Padma Bhushan Professor Naresh Trehan, Padma Bhushan Professor S.K. Sareen, Padma Bhushan Professor Dr. Ashok Seth, Padma Shri Professor Saroj Churamani Gopal, Padma Shri Professor Lalit Kumar, Professor Raj Kumar, Professor Rakesh Bhatnagar, Professor Rajendra Prasad, Professor R.K. Garg, amongst others. The Academy is working in close association with other national and international organizations, including the National Academy of Medical Sciences, India, for academic exchange programs. Moreover, in order to promote scientific interactions locally, IABS has also established centers at some institutions like Department of Biochemistry, MS University, Vadodara, Symbiosis University, Pune, and recently at Mumbai. Some of the prominent international supporters of the Academy are Professor Lindsay Brown, Australia, Professor Elizabeth Tyndall, Germany, Professor Pawan Singhal, Canada, Professor Tariq M. Happy, USA, Professor Chris Mulder, Netherlands, Professor Titus Augustine, UK, Professor Peter van der Spek, Netherlands, Professor Dr. Virendra K. Mishra, UAE. Most of them have participated in the various conferences of IABS. Recently, the 10th International Conference of Academy was jointly organized by Department of Biochemistry, King George's Medical University and Department of Biotechnology, Era University at Era University, Lucknow on 7th and 8th May 2022. The conference was organized in association with National Academy of Medical Sciences, India, New Delhi. More than 90 faculties, including 11 learned speakers from abroad, shared their experiences and talked about the latest achievements in biomedical research. The conference was attended by over 250 delegates, and it was organized by Professor Abbas Ali Mahdi, the organizing secretary. The conference was inaugurated by Padma Bhushan Professor Dr. Ashok Seth, Chairman Fortis Escorts Hospital, New Delhi, in presence of Padma Shri Dr. Mansoor Hassan and Dr. Ammar Rizvi as guests of honor. The function was presided over by Padma Shri Professor Saroj Churamani Gopal, ex-Vice Chancellor, King George's Medical University, Professor Hari S. Sharma from the Netherlands, Professor Thrupal Venkatesh, Bengaluru, Professor K.G. Raghu, CSIR, NIIT ST, Thiruvananthapuram, Professor Farzana Mahdi, Vice Chancellor, Era University, Lucknow, were also present on the occasion. During the conference, the annual convocation of the Academy was also organized, in which IABS fellowships were presented to many luminaries, including Professor Afrozul Haq, Vice Chancellor, HA University, Imphal, Manipur, Professor Ajay Singh, Director, PGICH, Noida, Professor B.S. Shankaranarayana Rao, NIMHANS, Bengaluru, Professor Farzana Mahdi, Era University, Lucknow, Professor K.G. Raghu, CSIR, NIIST, Thiruvananthapuram, Professor Suman Kundu, Director, BITS Pilani, Goa Campus, and Dr. Ramesh Chandra, ex-Vice Chancellor, Bundelkhand University, Jhansi. IABS annual awards were also presented during the inaugural function of the conference. The prestigious Padma Shri Professor Mehdi Hassan Award was presented to Professor Dr. Ashok Seth, Fortis Escorts Hospital, New Delhi. Moreover, Professor Sohail Ahmed Award was presented to Professor Alpana Sharma, AIMS, New Delhi, and to Professor Asadullah Khan, AMU, Aligarh. Mrs. Abida Mahdi Award was presented to Professor Saurabh Varshney, Director, AIMS, Devgarh and AIMS, Patna, and to Dr. Prasoon Priya Nayak, AIMS, Jodhpur. Lifetime Achievement Award was presented to late Professor Arun Rayazada. During the conference, more than 14 sessions were conducted, in which over 80 speakers presented their work. Furthermore, 3 poster presentation sessions were also organized for students, in which more than 117 delegates participated and presented their research work in the field of biomedical research. Thank you.
PPT. Yes. This is I hope that you got some idea about Indian Academy of Biomedical Sciences. Is one of the decent and dignified society. If you wish to join, since you are all medical background, if you wish to join as a member, as a life member, you are all welcome. You can contact me since I am a southern region representative. I will help you, and we are planning to organize one South Zone conference in this Nitte University. The discussion is going on with our Sucheta Kumari Madam and Prasant Sethi sir. Next year, maybe September or October, you are planning to have this South Zone IABS conference. Okay, if you are having any queries or any interest, you can contact me or you can contact our Sucheta Kumari Madam. Okay. Yeah, now I will come to my actual research is happening in my lab. That is the one. From morning we are speaking too much, about cytogenetic techniques, leukemia, how to diagnose the leukemia and leukemia, diagnosing and therapy. Only these three words I am hearing from morning. Leukemia techniques, cytogenetic techniques used to diagnose the leukemia, that type of things we are hearing from morning from stalwarts like Jairam sir or other professional clinicians. But we are not touched about that. What is the mechanism? Is a molecular mechanism is involved in induction of leukemia or onset of leukemia. That is the one we didn't touch. That is the one I am going to convey. I am going to give some idea, evidence to what is the mechanism is going to be happening at induction of leukemia. In that you can. Okay, this is the one, the global scenario of cancer. You can see this is the one. The sixth death in the world is due to the cancer. This is the one. You can see this is the one. 19.3 million new cancer cases, we recorded every year. 9.9 million cases death worldwide in 2021. Still we are having another 10 days time or 13 days time, but this many deaths. Okay, you can second leading cause of death, it's in developed countries. In third leading cause death in the developing world. You can see WHO is estimated that 30.2 million cases death will be in 2040. This is the case. If you see this India, you can see 30 cases at any time. 30 cases. You can see this over 11 lakh new cases and this many deaths in 2020. This is the one, if you see India is a single country contributing 8% of this one. Okay. In that, you can see this is the one. Number one cause of death in children is cancer. You can see this is the one. Cancer is the one is a dominating type of one. You can see this is the one. Every day 43 children are diagnosed with cancer. You can see this is the 60% of children who survive cancer. This is the one. One out of 8 children with cancer will not survive. This is the condition. This is the status of cancer now. In that, you can see this is the one. The ratio of childhood cancer, if you take, from morning we are discussing, we are mentioning this name is leukemia. In case of children, you can see that childhood cancer is a leukemia only. The leukemia is the most common form of cancer in children less than 15 years of age. Okay. In that, you can see this is the one, these are all, from morning we are discussing, that lineage and myeloid lineage, lymphoid lineage, and, this is the schematic view of hematopoiesis. This is the basic one. In that, you can see the classification of this leukemia, ALL, CML, all these things, what is the classification. From morning, all, clinicians and cytogeneticists have been mentioned. Okay, this is the one, no need to explain all these things. In that, this is the world incidence and geographical incidence of leukemia. This is the major one. What causes leukemia? Exactly we don't know. Causes of leukemia. It's unknown. You can see this is the one, high level of radiation or toxin exposure, like that people used to say. Many reports. The another one reports is viruses, genes, then chemicals, particularly pesticides and herbicides. In that chemical, the risk of agricultural pesticides, organophosphate pesticides. Organophosphate pesticides are the one is the one causing leukemia. How it is going to cause, what is the evidence, we don't know. This is the one. In that, you can see that agriculture, many reports. You can see that agriculture pesticide and risk of childhood cancers. You can see that residual proximity of agriculture pesticides. These are all the reports showing that the cancer is going to cause the cancer. The agriculture workers, the parents, they are going to be exposed to the pesticides, agriculture pesticides. This is the one at the time of gestation period, pregnancy period. They are going, parents are exposed prior to conception and after that in utero. That's, you can see this is the one, childhood. They used to be exposed. Direct exposure during childhood. Then you can see this is the one, the children. This is the WHO report, UNICEF one. You can see this is the one, it's the children are more vulnerable to the effects of pesticides. These are the one. In that you can see there are two pesticides, parathion and malathion, extensively used pesticides in agriculture field. Okay, these pesticide, particularly this malathion pesticide, that residues is present in almost all. You can see that agroecosystem, sediment in water or industrial area, rainwater, even river surface water. You can see the unfiltered water, drinking water pipes, urine also it is having, some fruits and vegetables. This residue is present. We don't have any direct evidence to show that the malathion is going to cause leukemia, but some of the reports, epidemiological reports, they are telling that it's a malathion exposure is associated with the risk of cancer, leukemia and lymphoma. You can see this 2007 report, that is the one issue. Whether this malathion is induced leukemia, we don't know. In that, the specific mechanism triggering this initiation of leukemia, we need to know, we need to study. We don't know, that is all this information you don't know, people just epidemiological reports. In that reports you can see this is the one, the first evidence, cytogenic evidence. Since I have trained one of my guide, mentor, Professor V. Vasudev from University of Mysore, and he served as a professor in Kuvempu University. I worked with him and I learned some of the techniques, cytogenetic techniques. That same thing I am using the techniques and I am doing some research. And also you have written one book, Understanding of Cytogenetic Techniques, that was published by Springer publisher. Okay, this is the one. This is the one first cytogenic evidence. You can see this is the one. It's a first cytogenetic evidence. It's a micronuclei formation. Simple technique. You no need to put lot of money or just it's a simple technique. You can see that it's a normal binucleated cells. You can see it's a unsegregated chromosome. You can see here is tubule. It's a MN chromosome, micronuclei. It's a chromosome break. It indicates that it's a chromosome break or loss. The micronuclei, the number of micronuclei indicate that it's a chromosome loss or break. You can see another one, nuclear bud. It is indicating the gene amplification. Okay. You can see that nucleoplasmic bridge is a dicentric chromosome, anaphasic bridge. Okay, these are the simple techniques to demonstrate cytogenetic effects of any chemicals. Just we are showing that a malathion, you can see this is the one. In case of control, in case of NAC is a N-acetylcysteine is an antioxidant. You can see that EMS, ethyl methyl sulfonate, and different concentration of malathion. Okay, this is the data. Just I am not going to tell that what is the data and other things. Just my interest to convey that what are all the techniques is there to convey effects of some chemicals and also molecular mechanism. In that, another one is a chromosome level. After nucleus level, chromosome level. Next step. In that next step, from morning we are talking about is a karyotyping, conventional karyotyping. You can see this is the one. It's a direct action. It's a single-stranded break or a double-stranded break. You can see the translocation or deletion, isochromatid, or even homologous staining regions. These are all chromosomal aberrations based on the direct action or indirect action. Indirect action means that any chemical, I have taken here malathion that induce the oxidative stress. This oxidative stress is nothing but free radicals. This free radicals is going to damage the DNA. The damaged DNA you can estimate using number of chromosomal aberrations, or you can go for comet assay, or you can do you can measure the oxidative level. These are the one chromosomal aberrations in EMS, control, and NAC and all these things. This is the one. Okay, in that you can see this is the one. Total number of chromosomal aberrations. You can see this is the one. In case of EMS, is a strong mutagen. It's a positive control. You can see in different malathion concentration also you can see this. That means that your organophosphate pesticide is going to cause genetic damage or DNA damage. You can see this is the another one technique. It's an old technique. People used to use the sister chromatid exchanges. Sister chromatid exchanges. You can see this is the one. Whether is going to induce sister chromatid exchange. It's another one technique we employed and we got the result. Okay, all these things is going to convey that. Another one you can see this is the one, is a very simple technique, it's a comet assay, single cell gel electrophoresis assay. Comet. It will indicate that its DNA is damaged. It's a basic technique, cytogenetic techniques. And also we have measured the oxidative stress markers like ROS, reactive oxygen species, lipid peroxidation, and different antioxidants level, SOD, superoxide dismutase, catalase. That is real effect is there. And we using that alkaline comet assay and modified alkaline comet assay, we also confirmed whether they are going to induce the oxidative free radicals or damaging the DNA. Whether they are going to damage purine base or pyrimidine base. These are all basics of techniques. Using that basic of techniques, you can demonstrate, you can confirm that they are going to induce some damage. Okay, these are the one karyotypic evidence. From morning, we are discussing about karyotypic evidence. In that karyotypic evidence, you can see this is the one, is a normal chromosome. Normal human chromosome. You can see this is the one. It's the marker. It's another one evidence. You can see this is the one interpretation. 46XY translocation T. This is the one. You can see another one example. The malathion is going to cause chromosomal damage. You can see interpretation, cytogenetic marker. And you can see this is the one, trisomy. You can see 21 trisomy is the one. Hyperdiploidy. You can see this is the one, 150 microgram of malathion. If you expose to human lymphocytes, you can see like this, trisomy 14. You can see this is the one, another one. These are all karyotypic evidence to show that the malathion is going to cause damage. Okay, these are all different. Then we employed another one, with fluorescent in situ hybridization panel. In that we have taken, we are not having too much of fund grants. We have taken some probes, simple probes, and we analyzed. This is the first probe, KMT2A probe. You can see this is the one. It's a evidence. You can see this is the one. It's a loss of KM2A copy. You can see that extra copy of KM2A or KM2A breakage. It's a normal cell showing KM2A fusion signals. This is the evidence. Evidence to show that the organophosphate pesticide induce some damage, or it will cause some. This is the another one is IGH. From morning, many slides IGH genes they are going to signals they are going to use. This involved in immunoglobulin. You can see this is the one, IGH copy. Normal and different one. Okay. You can see this is another one in case of metaphase chromosome. These are all the evidence to confirm that our malathion is going to cause damage. Okay. You can see this is the one, IGH break apart. You can see this is the one. Okay. So you can see another one, ABL1 BCR from morning, translocation, 9th and 22nd chromosome. See? Okay. These are the one, BCR ABL fusion genes and chromosome 9. Then ATM, minoxidil is also mentioned, ataxia, telangiectasia. Okay. P53 is a tumor suppressor gene. See, these are all the evidence. This is cytogenetic evidence to prove that chemicals are going to induce damage. You can see another one. We employed, after all these basic conventional techniques, we employed microRNA-analysis. MicroRNA-analysis, that result also you can see that the differentially regulated gene cluster. In that you can see that is a malathion versus control, 659s are upregulated and 3729 genes are downregulated. All these genes are involved in B, T cell proliferation or activation and differentiation of immunoglobulin production or emetopoiesis. These are all the genes. You can see this is the one, is a B cells. What are all the genes are involved? Some of them are upregulating, some of them are downregulating. It's a differentially expressing. Differentially expressing. You can see this is the T cells. They are involved in T cells. These are the genes. Okay. Again, you can see this is the immunoglobulin, some of the genes. Now, I am not going to explain all these genes. Just I am going to give you flavor of that. What are all the genes are involved. That's it. Okay. These are the one immunoglobulin genes. Okay. You can see again this is the one emetopoiesis. Some of the genes are involved in emetopoiesis. Okay. Then you can see this is the one is a sarcoma or ROS pathway. They are involved in ROS pathway or MAP kinase pathway. That is the one. Okay. Okay. These are the one. These are the genes differentially regulated. Then what we did is we validated these genes, whether these genes really expressing. That validation we made with RT-PCR. That result also it is proved that they are really affecting. They are really differentially expressing. These are the some of the genes. Okay. Now finally you can see that you see this one, cell viability. If it is MTT assay or colony formation assay, you can see that control. And even 50 mg per liter, you can see that by microgram per ml, there is no effect on cell toxic or cytotoxic. You can see this is the one. The low concentration of malathion, it induced the expression of genes even without causing any cytotoxicity. That means that they are not going to cause any cytotoxicity, but it will express their genes. The gene, they are going to modulate. That modulation leads to the cancer. How it is going to lead the cancer? This is our This is the one loss of genetic material. Means loss of genetic matter means monosomy or deletion. That means that loss of tumor suppressor genes that may leads to the initiation of cancer is a one pathway. The another one pathway is gain of genetic material. It's a duplication or double miniature. That leads to the amplification of oncogene. Then another one is it's a relocation of genetic material like translocation or inversion or insertion. This mechanism that gets a fusion gene generation or gene restriction oncogenes, that all leads to the initiation of cancer. That events it occur at molecular level. In that we are also proposed that these are the genes we know loss of function genes we observed in our study, and also gain of function genes we observed in our study. You can see that one loss of function of genes means it's a differentiation block. The another one is gain of function genes means is enhanced proliferation. That to it model like leukemogenesis that leads to the leukemia. Some of them are going to lose, some of them are going to be gain. Some of the genes. These are all genes we have studied in our study. That is the one evidence. In that now we can see that it's a normal blood cells. It's a blast. Morning they mentioned our clinician, one expert, he was mentioned about blast, leukemia blast. You can see here is a leukemic blast. Before that is a pre-leukemic state, is a first hit or even second hit that leads to the evolution of leukemia. These are all the evidences, molecular evidences to show that leukemogenesis. It's a first hit or second hit or any epigenetic mutation or genetic mutation, aberrant microenvironment, all this leads to the leukemia. These are all the molecular mechanism leads to the leukemia. This is my team. They are all working with me for this project. I thank Central University of Kerala and Institute of Immunoethical Committee for the permission, approval, genotypic technology, microanalysis, and all blood donors. That is very, very important. Thanks to them all, and also funding from different agencies. Thank you.
Thank you, sir. The topic is open for discussion.
I hope that I have not made any serotonin induced.
Sir, a very nice presentation. And for all research scholars, what they have to take home message from this presentation, you can take a project and with the 5 techniques you can prove that there is a damage. If you learn 5 techniques, your paper will go to Q1 and high impact factor. So this is the way any thesis should have these following techniques to prove your thesis. So otherwise we randomly do the work. So one work we have to prove in different techniques. So that will be the impact of the technique. So you are well explained, and even in our lab we had the BRNS project. We used to do radioprotective functions of various medicinal plants with this mainly micronucleus, chromosomal assay and chromosomal aberrations, and all of them to estimate antioxidant levels and there, but they are not touched the gene expressions. But these so many 5-10 people have finished PhD with this type of technique. It is very good, and you added how molecular changes, expression changes and everything. Very eye-opening for all research scholars for their any pattern of work. And very nice, sir. We are expecting your book so that any modification in our student study we can include. And it is a very add-on knowledge to the cytogenetics. And is there any questions from our side, our loving students? Is there anything? Okay, but at least you got the idea now. I am very grateful to Guru Shankar sir has given a real picture of any preparation for the modern thesis. Sir, very good, sir. Thank you very much.
Thank you, madam.
And I thank on behalf of our Center for Human Genetics and also Nitte Medical College, and on behalf of Nitte University, on behalf of all of us, we thank you very much.
Thank you, madam. Thank you.
Thank you, ma'am. I request our chairperson, Dr. Sucheta Kumari N, to present a memento to our speaker. Thank you, ma'am. Thank you, sir. Now I request Dr. Jairam Kadandale to present a certificate to Dr. Sucheta Kumari N for chairing the session. Thank you, ma'am. With this, we have come to the end of the CME on impact of cytogenetic analysis in oncotherapy on the occasion of decennial celebration of Kshema Center for Genetic Services. So if any of the delegates want to give a feedback, you can just come over and give us a brief feedback on the CME.
He's not there. He went out. He went out.
It was so informative. Thank you to cytogenetic lab and
Hello everyone. Yeah, this session it was very nice, and we have all the veterans and so much knowledge, so much. It's very motivating also to know this, and to maybe in future we also can give a little some contribution. Srishti, NMMIT internship. From my internship I got that motivation, like the chromosomal karyotyping from Reshma ma'am, and she also had talked about Jairam sir also, which is very motivating, and it's very boosting also. Thank you so much. Thank you.
Today's CME was a combination of knowledge. It was helpful for clinicians, for the laboratory personnel, and for students also. So on the diagnosis aspect, we had a very good talk from Dr. Rajesh, and I think many of our postgraduates also attended it, which would help them in diagnosis and subtyping of leukemias. On the technical aspect, there was a lot of talk on the different techniques and different procedures, which would be very helpful to PhD students as well as MSc MLT students. So on the whole, it was a very nice experience to learn from great people, diagnosticians, clinicians, as well as technical aspects. Thank you. Thank you for the CME.
Thank you, madam. Thank you. Thank you for all the delegates and speakers and our honorable guests. So at the end,
I thank all the delegates present here for accepting our invitation. Last but not the least, I thank all my colleagues for their cooperation in making this CME a resounding success. A huge round of applause to the organizing team. for making this CME a resounding success. Thank you, one and all.